Good morning, everyone. I'm Dr. Manjusha Shah, Secretary IMA. Welcome you all for today's CME on prevention of neonatal blindness, which is really very important for all of us, all physicians, healthcare workers, and even parents to know about the neonatal blindness and just to create awareness about it. We have organized this CME. About 2 lakh preterm babies, they born in India, every year are at risk of developing retinopathy of prematurity that can occur in babies born premature or with low birth weight. It is surprising to see that around 5,000 children go blind in our country every year because of low awareness about ROP among physicians, parents, and healthcare workers. So increasing awareness and training amongst pediatricians, ophthalmologists, obstetricians, it can save more children from getting this blindness, which is preventable. As you all know that 15 February is celebrated as World Retinopathy of Prematurity Day, that is ROP Day. So to create awareness about the same amongst all physicians, Indian Medical Association in association with IMA Solapur has organized this event with the help of Dr. Reshma Shah, who is a pediatric ophthalmologist, and she has taken lots of efforts to organize this event. Today we have eminent faculty with us from Bangalore, Hyderabad, etc. And they will guide us and will definitely, it will be beneficial to all of us. So I would like to invite all the dignitaries on the dais, President of IMA, Dr. Gurunath Vache, President IAP, Dr. Kundan Chopde, all the faculties, Dr. Anand Vinekar from Bangalore, Dr. Abid Ali from Hyderabad, Dr. Milind Shah, who will join virtually, Dr. Sandeep Kulkarni from Solapur, Dr. Reshma Mehta, and Dr. Girish Ingle. And my co-secretary, Dr. Sudhanshu Kothadia, and IMA Treasurer, Dr. Praveen Patne. So you know that it is our tradition that we start each event with Guru Vandana. Thank you. Now I request all the dignitaries on the dais to join for lamp lighting.
आरोग्यं धनसम्पदं शत्रुबुद्धिविनाशनं
Now, without wasting much time, we will start with the main program, CME, and I will hand over mic to Dr. Reshma Mehta.
Thank you, IMA members, office bearers, President Dr. Gurunath Vache, Secretary Dr. Manju Shah Madam, Dr. Sudhanshu Kothadia, IIP office bearers, President Dr. Kundan Chopde. I welcome all the speakers, Dr. Anand Vinikar sir. Thank you for accepting my invitation and gracing this occasion and being a part of this program today. Thank you, sir. I request Dr. Manju Shah Madam, Secretary of IMA President, to welcome Dr. Anand Vinikar, sir. I request Dr. Sudhanshu Kothadia to welcome Dr. Abid Ali, sir, who has come from Hyderabad. Thank you for accepting our invitation and being a part of the program today. I request Dr. Kundan Chopde, sir, IIP President, to welcome Dr. Sandeep Kulkarni, sir. Thank you, Dr. Sandeep Kulkarni, sir, for being a part of this program today, in spite of your busy practice. Come so long from Solapur. I welcome Dr. Ingre sir. Dr. Patni sir will welcome Dr. Girish Ingre sir. He will be telling us about his journey to Antarctica. Please welcome Dr. Girish Ingre sir. And we have Dr. Milind Shah, gynecologist. He will join us virtually from Indore. We start with the CME. I request all the guests to take place and to be seated.
It's a wonderful video created by Dr. Reshma Mehta. So to start with the CME, actually we will start with this video first and then about the lectures.
है सुना ये पूरी धरती तू चलाता है, मेरी भी सुन ले अरज मुझे घर बुलाता है। भगवान है कहाँ रे तू, है खुदा है कहाँ रे तू।
एक तू ही सहारा, इस तेरे जहां में नहीं कोई हमारा। ईश्वर या अल्लाह ये पुकार सुन ले, ईश्वर या अल्लाह हे दाता। हमसे न देखा जाए बर्बादियों का समा, उजड़ी हुई बस्ती में ये तड़प रहे इंसान। तू ही भरोसा, एक तू ही सहारा, इस तेरे जहां में नहीं कोई हमारा। किसे पूछूं है ऐसा क्यों, बेजुबां सा ये जहां है।
खुशी के पल कहाँ ढूंढूं, बेनिशां सा वक्त भी यहाँ है।
जाने कितने लबों पे गिले हैं,
जिंदगी से कई फासले
यूं आंखों में लकीरें जब छूटे इन हाथों से यूं बेवजह।
जो भेजी थी दुआ वो जाके आसमां से यूं टकरा गई कि आ गई है लौट के सदा।
जो भेजी थी दुआ वो जाके आसमां से यूं टकरा गई कि आ गई है लौट के सदा।
नई नजर से चल दुनिया परखें, जहाँ तेरा गलत ना मेरा सही हो। सोच को अपनी छूने दे अंबर, जैसे हवा में एक पतंग उड़ रही हो। तू बदले तो ही बदले जमाना, औरों से पहले खुद को ये समझाना।
I think this video tells a lot. So we have gathered here to celebrate the World ROP Day, which is on 15th of February. There are 15 million preterm births every year in India. And as you've seen in the video, 5,000 children become blind every year all over India. We have a lot of good NICU care in all the Solapur district, even in the remotest of the rural areas in Solapur district. But I feel very sad when we see a blind child and when we see that the baby could have been saved, but still the baby is presenting to me as stage 5 ROP. It is very sad. So it is my aim or my motto to create more and more awareness for ROP screening. And hence we have gathered here to not to have any baby in the ICU which will become blind, and to do more and more of screening. So as we have seen, more premature babies are surviving, and hence the incidence of ROP has also increased. There were 2 incidences in past 6 months where 2 neonates came to me from a very well-to-do family and which have gone blind due to ROP. And there were simple reasons that the baby was admitted in the NICU. KAP, that is knowledge, attitude and practice of the pediatricians, of the neonatologists and of the parents was estimated. We asked, there was written on the discharge card that you have to do ROP screening, but the attitude of the parents or grandparents was, we will do it when there is good weight gain of the baby. And the practice that they came and presented very late. The window period is very important between diagnosis of ROP and the treatment given. These neonates will live for next 60 to 80 years. Hence, we should not miss any baby which will become blind due to ROP. It is my main aim or motto just to screen and continue screening and improvise screening in the remotest area of Solapur district. We start our CME here, and I invite our first speaker. I introduce Dr. Abid Ali sir. Dr. Abid Ali sir, introduction. I welcome Dr. Abid Ali. Dr. Abid Ali is a young, dynamic neonatologist in Solapur. At present, he is a consultant neonatologist at Ankura Hospital, Hyderabad. He has completed his DM Neonatology from Lady Hardinge Medical College, New Delhi. He has also completed a 3-month training from Oslo University Hospital, Norway. He completed his MBBS from VM Medical College, Solapur, and went to Mumbai to do MD Pediatrics from KEM Hospital, Mumbai. Post DM, he worked as a consultant neonatologist at Ashwini Sahakari Rugnalaya Solapur and at Span Hospital. His special interests are working with the prematures and sick-term neonates. I welcome Dr. Abid Ali's.
Thank you, IIP Solapur and IMA Solapur for giving me opportunity to talk. I have a talk on today, and I'm very grateful to have share the dais with Anand Vinekar sir, who has done immense work in ROP. And as the ma'am's last video has made us very emotional, that the boy with showing on torch was not focusing on that. So it makes us very emotional that baby is surviving but he's going blind. So that's the importance, my topic today, importance of universal screening. Indian childhood blindness can be can occur from globe, cornea, lens, retina or optic nerve. Of these, vitamin A deficiency, cataract and ROP contributes a major to it, and most of them are preventable. Government of India through RBSK have implemented which targets at 4 Ds, which is defects, deficiency and diseases and development delays. Through these RBSK, Government of India have laid down guidelines for universal eye screening. Early eye examination is vital because it is not only result in blindness but also affects the cognition and school performance. Every newborn which has burned at delivery site should be screened undergo universal eye screening with pictorial tools before discharge, that is before 72 hours. And any newborns which are requiring admission at NICU also should undergo this same screening by pictorial tools, and additionally preterm should undergo ROP screening. This is the pictorial tool which all pediatricians must be aware of and using it, and also direct ophthalmoscopy for red reflex. ROP is a clinically silent in newborn periods, hence it should be actively screened and promptly treated. Before going to on protocol for ROP screening and treatment, I'll go through just on epidemiology, risk factors and pathogens of ROP. In India, almost 3.5 million preterm births occurs every year, and more than 3,000 preterms go blind every year. And incidence in India of ROP is 20 to 30%, and so at some centers it may go up to 50% also. And about 10% of babies develop severe ROP. When till now we have 3 epidemics. When initially first epidemic occurred in 1940s to 1950s, where because of unrestricted oxygen use, but in late 1970s and 1980s, because of increased survival of preterms, smaller babies, second epidemic occurs, and in developed countries. But in developing nations like India, there has been third epidemic because of increased survival of preterm newborns, but with inadequate quality of neonatal care and lack of infrastructure, and low coverage of screening and treatment services. Well-established NICUs have gradual decline in incidence of ROP, but as the ma'am said, more or more cases, recent reports of ROP are from peripheral centers and neonates which are being referred from district hospital to tertiary care centers. Nowadays, more mature, in India, more mature and heavier babies are developing ROP. And even now, babies came first time with a stage 5 ROP due to lack of screening, as ma'am already said. As we have seen, the major risk factor are 3. Prematurity, as incidence of ROP increases as the gestational age reduces and birth weight reduces and also with use of high oxygen concentration. So in regard to oxygen, there have been large meta-analysis done which is known as NEOPROM, which is the meta-analysis of 5 RCTs, support trial, core trial, boost trials, which shows that when we maintains lower SpO2 target of 85 to 89, there has been reduced in incidence of ROP, but at the same cost of increasing death and increased chances of NSC. So there have been suggestion for using FI to target SpO2 target of 91 to 95 and not more than 95. So whenever in an ICU we see SpO2 of 96, we should try to come down on FI2. That is important. Also, avoiding hyperoxia in first phase is very important, and even fluctuation in SpO2 intermittent hypoxia also increases the risk of ROP. Other risk factors, back nahi hoga? Yes, it's okay. Other risk factors are acidosis, sepsis, liberal blood transfusion, RDS, and poor postnatal weight gain. When you see normal retinal vascularization, it begins from 16 weeks of gestation and completed to 32 weeks by nasal ora serrata and to 40 weeks at temporal ora serrata. And there are two phases of in ROP. When baby is within the womb, the normal SpO2 highest oxygen saturation within the uterine vessels, umbilical vessel is 70 to 80%. But when baby comes premature and come out, so it's exposed to higher oxygen saturation, which sends signals that no more vascular growth factors are required. So there is reduction in VEGF, which leads to arrest in vascularization. But in second phase, because of intermittent hypoxia or hypoxia, it leads to again increase in level of VEGF and other growth factors, leading to abnormal vascularization, pathological new vascularization. And these vessels are leaky and have tendency to grow extraretinal and leading to ROP. So important part, which baby, whom do we need to screen? When we see the Western guidelines, they have cutoff of gestation of 31 weeks and 1500 grams. But this is the study published in IJO by Anand Vikasar only. When we follow these Western guidelines, we are going to miss 18% of ROP and 23% of babies with ROP with American Academy of Pediatric Guidelines and European guidelines. So there was a need of having Indian guidelines. So RBSK have laid down Indian guidelines, which says any baby less than 2 kg or 34 weeks needs ROP screening, and any baby with 34 to 36 weeks with having prolonged oxygen therapy, RDS, exchange transfusion, poor postnatal weight gain should be screened for it. So simply we can keep understand that 2, 3, 4. What is 2? Any baby less than 2 kg, and 3, 4 is less than 34 weeks. So simply remember 2, 3, 4. So all preterm should be screened at 4 weeks of life, and baby who are less than 28 weeks and less than 1.2 kg should be screened at 3 weeks. This is why, because there is one more term called AROP, which is previously known as APROP, now called aggressive ROP. For that purpose, we need to screen at 3 weeks. But no ROP should be screened done before then 3 weeks, because unnecessary causes disturbance to the baby. So who can screen? And a trained ophthalmologist who is well versed with the indirect ophthalmoscopy and laser therapy, but there are lack of less trained ophthalmologists in ROP especially. So they have trained paramedics, technicians for the ROP screening at remote site with help of red cams or wide field angle cameras. ROP should be done in an ICU and not preferably in the OPD or ward. And ROP can be done on critically ill infants on ventilator also and incubator also. We can see that babies on venti undergoing ROP screening, and this is the old picture of Mangat Dogra sir doing ROP screening on the incubator. So what instruments we need for ROP screening? These are the indirect ophthalmoscope, 20 or 28 diopter lens, speculum and scleral depressor. There are various combination of eye drops for mydriasis, combination of 0.5% tropicamide and phenylephrine, which is available as Tropac P, can be used for dilation. Consent should be taken before ROP screening, and baby should be fed 1 hour before the screening and with connected to a pulse ox monitor for looking for the event. And hand hygiene sepsis should be strictly maintained, and post-procedure antibiotic shot drop should be used. Documentation is very important because it has a very medico-legal implication. Sandeep sir will talk on that. And this is the chart or say pro forma which we use for ROP screening. No term should be used like immature retina or no ROP. Rather than that, we should use incomplete vascularization accompanied by zone of vascularization. So we can, for example, incomplete vascularization into zone 2. Details of zones I have not covered. So at the end of screening, there are only 3 outcomes. Baby doesn't need any further follow-up. Baby needs follow-up screening, and baby needs urgent treatment. Follow-up generally we should do at 2 weeks till the retinal vascularization completes or till the ROP regresses or ROP requires treatment. Baby with more type 2 or in case of type 2 ROP like stage 1 or 2 in zone 1 needs or stage 3 in zone 2 needs earlier follow-up 1 week or less, but with stage 1 in zone 2 needs like 2 weeks follow-up. So when we should terminate this ROP screening, we should do ROP screening till 40 to 45 weeks when the complete vascularization occurs or there is regression of ROP. This nowadays prediction of, we can predict earlier who will baby are going to develop ROP. This is a wonderful study is done by the Anand Vinekar sir again, for which at the first screening how much the immature retina we can predict at baby later on can develop into ROP. We can see that when vessels are only in zone 1 or zone 2 posterior, they have high chances of developing type 1 ROP, 63%. But when their vessels are at first screening only, they are reaching till zone 3, there are only less chances of developing ROP. There is another various ROP prediction models are there like WinROP and so on. These are web-based algorithms which includes gestational age, birth weight, weekly postnatal weight gain and serum IGF-1 levels. With this and other models are ROP score, EROP study and PINT ROP CHOP models. So ROP is a preventable condition. So ROP is a classical example of all prongs, all strategies of prevention like primary prevention, secondary prevention and tertiary prevention. Primary prevention by obstetric care, Milind Shah sir will talk on that. In case of neonatal care, whenever baby is born, we should avoid resuscitation with 100% oxygenation. NRP says resuscitate with preterm less than 35 weeks with blended oxygen 21 to 30%. And early use of early CPAP and avoid as far as possible invasive ventilation. There should be reduction in large fluctuation in oxygen saturation and proper oxygen target of 91 to 95 should be maintained. Early breastfeeding increases promotes the weight gain and reduces the chances of ROP. Use of KMC and measures to reduce the rates of sepsis greatly reduces the chances of developing ROP. And avoiding the unnecessary blood transfusion. As per Indian ROP Society, there are less than 200 ophthalmologists who are trained in ROP screening. There should be CME or workshop for training of ophthalmologists for ROP. And we can use those paramedics or technicians for ROP screening at remote areas with red cams or wide field angle cameras. And KID ROP has done wonderful work for prevention of ROP at remote areas. Sir is the pioneer member of that KID ROP. Also, there should be one doctor and one nurse should be designated for ROP screening. They should be well versed with protocols, when to screen, whom to screen, what time to screen. And there should be ROP register should be maintained, including all details of birth, gestational age, and what timing of ROP we are going to do and their findings. And whenever baby is referred from one center to another center for further care, there should be details of ROP screening and when to follow up should be given to other center. And there is various times there is lot of confusion when to do ROP screening. Jalali Hotel have said that 30 दिन रोशनी के, in which means first screening should be done at 30 weeks, and in case of smaller babies, 20 days of life. So ROP is a time-bound disease. So whenever as soon as we diagnose ROP, baby is having type 1 ROP, treatment should be begin within 48 hours. And in case of AROP, it should be done as early as possible. Parents have more confidence in the neonatologist, and nurses have frequent interaction and they are involved in daily care. So both neonatologists and nurses should counsel to the parents regarding the need of ROP screening and treatment. And ophthalmologists can explain that procedure of doing ROP screening is harmless. And at peripheral centers, ASHA workers can do daily home visits and improve the compliance for the follow-up of the ROP. So whenever baby is discharged, is clear mention should be made that when the parent should come, date, time, and exact venue where to come at the OPD, and ROP card should be handed over to them. As ROP requires multiple screening, even after discharge, if there is lack of proper communication to parents from the doctors or healthcare professional, this leads to reduced compliance. And lack of awareness about the rapid progression of the disease. As soon as disease develops, there has to be treatment. So if they are unaware that about the rapid progression of the disease, it can lead to developing into blindness. This awareness can be done with the help of print and electronic media, ROP walks or runs, or hoardings with celebrities like Amitabh Bachchan or doing for Pulse Polio campaign. This is the ROP patient information sheet in Hindi language we can give to the parents for awareness. Tertiary prevention can be for the treatment of complications. There should be audit should be maintained for how much this ensuring the ROP screen is going in the NICU setup with use of percentage of babies who are undergoing at least one ROP examination, and the percentage of baby who are having first ROP at exact 4 weeks of postnatal age, and percent of baby who are requiring treatment for ROP and they are being treated within 48 hours of decision being made. So take home points: every newborn must undergo ROP screening. Oxygen is a major culprit, so we should avoid oxygen toxicity. NICU practices like asepsis and avoiding liberal blood transfusion are very important. Strict adherence to screening guidelines, timely diagnosis and management can prevent long-term impairment. Awareness of public healthcare professionals is a key. Telescreening with the help of red cams and predictive model can be useful in future. Thank you. And this 30 दिन रोशनी के everyone should remember, and 2, 3, 4 less than 2 kg, less than 34 weeks. Thank you. Thank you.
You've said 30 दिन रोशनी के, but last month we had twin babies at Span Hospital, where I was called for the ROP screening, and the baby was not even 30 days, but the baby, when I saw the picture, it was AROP, and it was very, very alarming. So we thanked Dr. Abid Ali sir that though the patient baby has not completed 1 month of life, you have called us for ROP screening, and we could save by giving anti-VEGF, and then we did laser. So the baby's vision was saved. It is only because of Dr. Abid Ali sir who thought of screening at the right moment. So can you tell us why you thought that it was twin pregnancy, there were comorbidities also, but he will explain in detail.
As I have said on the slide, ROP screening should be at 4 weeks. But in case of babies who are born less than 28 weeks or less than 1.2 kg, they have more tendency to develop AROP, which was previously called as APROP, aggressive posterior retinopathy of prematurity. But at 21 days or say 20 days of life, they should be screening for this kind of entity. This more seen in developing countries like India. So to prevent that, at 20 days of life, screening is a must. Because if AROP is there, as type 1 ROP, I said treatment should be within 48 hours. But in case of AROP, as soon as you find AROP, we have to go for treatment. Thank you.
Many times we see that the babies are born at around 34 weeks and all. And the stay in NICU is maybe around 15 days or something. And we definitely ask them to come for follow-up at 1 month of age for ROP. But sometimes we are afraid that we may lose that baby, that the baby may not come, as madam said, कुछ families ये रहते हैं. So in that case, can we do a basic ROP screening before discharge, maybe at around 3 weeks or something like that, before discharging the child?
There is something called as universal screening, which Dr. Anand Vinikar sir and rest of them also advise. Universal screening, like whenever, if Tuesday is the day that you have decided for ROP screening in the particular NICU, that day all the babies in the NICU should be screened without the thing that whether they are going to be discharged or not discharged. So at least they will be under the cover that any baby is suffering from ROP. So universal screening is what Government of India is also promoting now. Our next speaker is Dr. Anand Vinikar sir. I would like to introduce him through a video. Dr. Anand Vinikar sir. I welcome Dr. Anand Vinikar. Dr. Anand Vinikar is currently the professor and head of department of the Pediatric Retina Service at Narayan Netralaya Eye Institute, Bangalore. He is the founder member and the founder program director of Kid Drop program. Kid Drop is India's first tele-ROP program to screen for retinopathy of prematurity in rural areas and is currently one of the largest ROP programs in the world, having completed over 1,60,000 screenings in over 125 neonatal centers. This data is from 2020. The program has won several national and international awards. The program has been cited by UNDP, Niti Aayog, Harvard Business Review, IIM, A and B, and validated on the CDC guidelines, and has been modeled by several states in India as well as some nations around the world. He is an honorary technical committee member of the National Task Force for ROP Government of India and served as a member for the Queen Diamond Jubilee Trust for ROP UK. He is the founding secretary of the Indian ROP Society and member of the Indian Medical Association Committee for Prevention of Infant Blindness. He is a member of the ICROP Committee 3. Dr. Vinikar graduated from St. John's Medical College. He completed his MS Ophthalmology with a gold medal, did his retina senior residency from PGI Chandigarh. He has been awarded the FRCS Glasgow, DNB and FPVR Fellowship from USA and has achieved the PhD in ROP from Netherlands. He has a degree in hospital administration too. Achievements and awards. Dr. Vinikar has won a university record of 17 gold medals in MBBS, the Pope John Paul Citation and Medal, the Kataria Gold Medal awarded by Prime Minister of India, the All India Young Researcher Award, Sight Saver Citation Award, Positive Health Award, C.S. Bhaskaran Endowment Oration Award, J.M. Pahua Award, K.R. Datta Award at AIOS, the AIOS IGO Gold Medal, M.M. Joshi Award, Colonel Rangachari Award, the Innovator Award at 2018 by Department of Biotechnology, Government of India and Innovator of the Year 2019. He has more than 90 publications. He has written more than 25 chapters and has one textbook to his credit. His special interests include retinopathy of prematurity, telemedicine, tear biomarkers, low-cost innovative imaging and artificial intelligence. I welcome Dr. Anand Vinikar. Anand Vinikar, sir.
Thank you, Dr. Reshma, for that very flattering and honoring introduction. Some of that data I don't know where you got from, but amazing homework. So I'm going to present, I know it's 45 minutes and that's very daunting because 45 minutes is, I'm told the attention span nowadays is about a 1 minute reel on Instagram, so 45 minutes is going to be hard. Well, these are some of the topics I'm going to cover, but mostly in the Indian perspective. So firstly, why this new classification? I think we're very honored that the new classification that came out just about 1.5 years back actually has for the first time Indian authors and authors outside the US and UK. And because the kind of diseases that we see is very unique and it had to be accommodated in this new classification. So two of us represented the subcontinent here, and This is not really, and I understand that almost all of you all are either pediatricians, neonatologists, or even physicians, and almost no one here is an ophthalmologist. So as part of my talk, which was meant more technical ophthalmology, we'll skip over. The idea is to understand the larger principles than actually get to know the names. So what's important to know is the classical stages of ROP have almost not changed, but a few subtypes have been described, and that's only so that we can tune our treatment, when to operate, when some outcomes may be better. So that's where the new classification is. Also, a lot of you neonatologists will be noticing that some of the ROP specialists write this zone 1 notch. So this is the notch. When the disease comes inside the macula, it's called a notch, and therefore it's more severe than if the disease was just a little far away without making that small incursion. So this has now been given a name in the new classification. Plus disease, pre-plus, all of us know if there is plus disease, we must do the treatment. But unfortunately, plus disease is not so sacrosanct that the moment you see it, there is a 100% way of saying, yes, this is plus disease. Understanding the fact that there is a lot of variability in this plus disease, this new classification lays that variability out, saying that you and I may disagree on what may be somewhat plus disease, but almost all of us will agree on what is definitely plus, and almost all of us will agree on what is not plus. Now, why is this variability important to put down on paper? Because medically and legally, there is a very important reason to do so. Because if I say that I'm treating this baby because there's stage 2 with plus, and a fellow colleague says, no, there's no plus, and tomorrow this case goes to court, either I will be accused of over-treating or that person accused of not treating on time. So the fact that this variability exists in nature and has always existed has now come on paper. Optical coherence tomography, or OCT, which is almost universally used by ophthalmologists, has made an appearance in this classification. Not that you needed to make a diagnosis, but it's important that we are understanding some aspects better, and I'll touch upon a few of those. The biggest contribution from India is this aggressive ROP. Earlier it used to be called aggressive posterior ROP. So what has been dropped? The word posterior, which basically means that even anterior disease, or disease that is going far out of the periphery, closer to the ora, which is the edge of the retina, can also be severe enough to be classified as aggressive ROP. There is a spectrum now of aggressive ROP. Earlier we thought it was called rush disease. Earlier we thought that blood vessels had to be dilated and tortuous only in the center, only in zone 1, to be called plus, or to be called aggressive posterior ROP. But today we understand there is a spectrum, and in fact all of these images of aggressive ROP have come from India. Here is an example of the disease that is going all the way up to the periphery, but these bald black areas show there is capillary non-perfusion there, which means that even though the blood vessels seem like they are growing far out, actually the perfusion is so bad that you must treat this as much as a posterior disease. Also, we traditionally believed that it had to be dilated and tortuous, but today we see a highly obliterated version of aggressive ROP also, and in fact those are the most difficult to treat. And why does that happen? Well, they talk about a golden hour, and I think we learn it from you as neonatologists, that if 100% oxygen is given in the first 1 hour, and after that you take over and give possibly the best neonatal care in the world, unfortunately the damage may have already been done. The vaso-obliteration that happens in these blood vessels, subsequently when they dilate, start creating patterns of what's called the obliterative form of aggressive ROP. We classically see this, as Dr. Abid said, variable levels of neonatal care. So they go from one center to another, either because of affordability or accessibility, and every time the neonatal care varies, you might actually have patterns on the retina which obliterates and dilates, and obliterates and dilates, almost like a sausage pattern. And you can almost tell at which week they went to which hospital. So it's really like a gynecologist placing a hand on the fundus and declaring how many weeks of gestation it is. We can look at the retina and find out at what week what problem is there. Stage 5 has undergone a small change in the classification. Now there is 5A, B, and C. It depends on how much of the front and the back portion of the retina you can see. I won't get into technical details, but this is important from a surgical point of view. 3 new terminologies, actually 2 new terminologies, the first and the second that you see here, have been introduced in the classification. Regression, exactly what the English language word means, that it is becoming better. Now there's either complete regression, which means good, it became completely normal, or incomplete regression, which is now gaining importance because of anti-VEGF medication. Unfortunately, and as you'll see in my presentation, almost no baby becomes completely normal after a single dose of anti-VEGF. There are exceptions, of course. So a majority of them have to be followed up and treated with some other treatment. Right now, that some other treatment is supposed to be laser. When and how, we'll refer to. So regression or incomplete regression has been given a new term now in this classification called persistent avascular retina, which means a part of the peripheral retina has not received any blood supply. Earlier, we would ignore it. Okay, so what? There's no disease, let's let it go. But longitudinal studies from all over the world have shown that these children who grow up to young adults and adults eventually, if they don't have part of their retina vascularized, will have a much higher chance of retinal detachments and complications as they grow older. So now there is something called clinically significant persistent avascular retina, which is 2 disc diameters, roughly 3 millimeters, that's all. So if there is 3 millimeters or more of avascular retina, we must attend to it and do treatment sometime. Logistics, we'll talk about. Regression has signs, we won't get into that. Another important, reactivation. Now this term almost did not exist in the pre-anti-VEGF era. When we did laser, it was a very definitive treatment. Almost all babies did well. India boasts of a success rate of 95% plus after laser, much better than many other countries. But after anti-VEGF, we have now this situation where despite it becoming better, it now starts becoming worse after some time. What is that time interval? How long do we keep this window of opportunity of screening? When do we intervene? These are questions still being answered. But regression and reactivation have patterns that have been described in this classification. So either the reactivation can be in the blood vessels, the plus disease coming back. They can be reactivation with the ridge coming back. They can be a reactivation in both coming back. In a new location, in an old location, in both locations. So this makes it highly difficult to diagnose because you're having problems of all forms in all places. The third terminology is long-term sequelae. Really nothing has changed from the previous classifications. But this new term, which I've highlighted, which we just spoke about, persistent avascular retina. Very important. As pediatricians and neonatologists, you all must make your ophthalmologist accountable to what's happening to that PAR. A lot of this has been covered by Dr. Abid, so I'm going to just go through it quickly. Just some pre-screening protocols. ROP screening actually happens a day before, maybe even a week before if you're calling the mother from a remote area. Do a fixed schedule. Make the nurse mark out the warmer. A day prior, the parents should be either called if they are coming from outside. Have a consent form already signed. Yes, a consent form is required for every single screening. A blanket screening consent is not completely ideal. Confirm the systemic stability, which is what we do when we interact with you, and fill out a pre-registered card and keep the card ready. Dilate appropriately, not excessively, and if the pupil doesn't dilate, remember there could be tunica vasculosa lentis, don't over-dilate, just wait for the ophthalmologist to come back. As he very rightly put, the mnemonic is really 1, 2, 3, 4, which means the first screening should be done for less than 2 kilos and less than 34 weeks. I think all of us, if we go back with one message, it should be that. And yes, the previous NNF guidelines, which we were all part of, had some ambiguity that less than 1750 is compulsory, 1750 to 2000 grams, only if there's risk factors. Fortunately, we've done away with that confusion from 2017, 2018. And in the new operational guidelines, we're very clear that the others are only called contributory risk factors. And the only risk factor that remains really is prematurity. Yes, 30 din Roshni ke, definitely before 30 days, as the example Dr. Reshma gave. It doesn't mean you have to wait for the 29th day. As Sir asked here, can I screen once before that 30 days? In fact, that has come into this provision. This was a study that we did in 2 rural areas. And we found that if we did one screening before discharge, we had a 8 times higher enrollment and a 12 times higher compliance than waiting for the conventional 3 to 4 weeks. So subsequently, this has made it into the national guidelines. So I think you're very much in legal terms to do one screening before discharge, even if the baby is a few days old. You know you may not see ROP, but what ends up happening, as you rightly said, is that you capture the parental detail, you counsel the mother and father, you show them the image, 100% they'll come back. We are also the first country, and I'm proud to say that we have used non-ophthalmologists or non-physicians legal permission, as long as they're of course trained and accredited, to do imaging-based ROP screening. We are the first as a national committee to come out with these guidelines, subsequently adopted by several SAARC countries and other Latin American countries as well. So there is a way of accrediting technicians, and that's laid out in black and white literally. There are levels of technicians based on their speed, more importantly on their accuracy. How we've done it differently in India is that we train these technicians not only to take the picture, but also to make the initial diagnosis, because telemedicine is just a backup platform for us. The technicians counsel, they fill up the card, they are the liaisoning officers literally between the parents and the neonatologists and us ROP specialists. As he showed, yes, when we can do the treatment through the incubator wall, why wait for the baby to become systemically stable to do the ROP screening? In other words, when you can do the treatment, you can certainly do the screening even if the baby is incubator dependent. If we wait, the risk is that the severest disease is seen in the sickest babies. And if we wait for these to become so-called systemically normal, that might be too late. This is me screening years ago in a rural area where we don't even have a platform. So I've just placed the baby, and in fact, this is doing treatment of the baby on the RedCam platform itself. So all we need really is just a space of 2 to 3 feet. Can be done anywhere. You don't even need a dark room. Never discharge a baby before 40th week of postmenstrual age. Legally and clinically, as he also showed, the normal vascularization would not have happened till then. So don't discharge before 40. When in doubt, call the baby back after 2 to 3 weeks. Documenting is extremely important from a program perspective and from a legal perspective. The ideal way is to share your documents in the NICU. This is what we maintain. So there's one white paper that we take back. The yellow carbon copy is left behind in the NICU. They need their data. They have NABH accreditations. They have surveillance meetings. More importantly, they need to contact the parents as well for follow-up. So make sure your team is updating this register every single visit. But what's even more important is to give out this information to the parent. Make sure this ROP card is filled out. The date, time, and venue is clearly mentioned. There have been instances when NRI parents have been called on, who were supposed to be called on 4th of April, have come on 5th of May because month was written before, and in America they write the month first, and in that 1 month later, the child has gone blind. So in difficult months like April and May, where 4-5 and 5-4 may mean different to different things, it's better to write APRIL 5th or MAY 4th. And these are small cultural things that we tend to neglect, and it has happened in real life, and then court cases do happen. Documentation is very much part of the operational guidelines. ROP screening is incomplete if you've not documented it. This was our program being evaluated by the CDC guidelines in the Australian government actually. And I just want to take out one screenshot from their report, and this is an independent report submitted to government. Says that if you do it in the traditional way of indirect ophthalmoscopy, it may be inadequate. With inadequately trained ophthalmologists, it may have the danger of suboptimal management of care. So today as we go forward, whereas imaging is not universally available, we are trying to drive the costs lower and make it more portable. There will come a time when ROP screening without imaging is not considered ROP screening at all, and we need to be prepared for it. And again, happy to let you know that we as a country are leading this effort in many other countries in taking imaging-based screening, especially in the outreach. Yes, this is the paper that Dr. Abid referred to. Look what else we found. So these are preterm babies. While we are screening for ROP, we are finding eye cancers. We're finding neonatally required treatment of vasculitis, sepsis, fungal sepsis. We have at one point discovered a fungal retinitis in a baby who had pre-renal abscesses of candida, which got picked up first as a retinal findings, and 8 days later the baby became toxic. If you look at your own literature, this is almost, the morbidity is very high. But because of a high degree of suspicion from a retinal finding, this child made it with intravenous amphotericin. Child's doing really well, about 12 years old now. So the number of eye findings that can pick up other systemic conditions are huge, especially in this precious cohort of preterm babies who have so many comorbidities. But this was 2012, this paper of universal screening, and subsequently RBSK in 2013 took the model and said every baby should be screened for 30 conditions. Unfortunately, other than ROP, we don't have guidelines on how this universal screening should be done for all other conditions. But happy to let you know that as of last week, in fact, the WHO has teamed up with Government of India and has commissioned an advisory committee group, and we just met online just last week, and hopefully in the next 6 months there will be some guidelines from Government of India as well. Newer imaging devices, again, so happy to let you know that all these innovations have happened in our country. This was the Neo, which we sort of had a collaboration with. As it was an academic collaboration. We have no financial interests. We teamed up with this Bangalore-based company who otherwise had a track record of making adult retinal cameras, and this was the ROP camera. And they had a collaboration with IIT Chennai, which helped them with their software, and they developed the hardware, and we did the field testing. This device has now got an CE and FDA approval, has installations all across the world. But what's new, and that's about 5-6 years old now. So what's new is this device, which is also subsequently, I believe, has received the CE approval, and they have applied for the FDA, is the angiogram unit. So the only device that is currently capable of doing angiogram on a baby, a supine baby, is the RetCam 3, which is a non-portable version of the RetCam, which today's cost is 1.7 crores, the newer model, which is unaffordable and of course non-portable. So this device is the angiogram module on the Neo camera, which is now completely tested. We completed the clinical trial. We are now writing it up for a publication, and it's doing, and in this era of anti-VEGF, it is going to be extremely important, and I'll show you why in a minute. There are other even more low-cost innovations. These are mobile phone-based adaptations. So this one comes from Ahmedabad, and the other one comes from Delhi. This is the one from Ahmedabad. Basically, they use a stand that fixes the mobile phone on top, and below is the 20 diopter lens that all of us clinicians use to look into the eye. It's great for photo documentation, but its use in a real-world setting of telemedicine is limited, because it doesn't have a support system. Also, there is some skill that's required. Plus, the field of view is all that a 20 diopter can give. The illumination system and the capture unit may come from your mobile phone, but eventually the lens unit is the 20 diopter. Whereas these wider field cameras, like a couple of others that are coming out from India, have a 120 or 130 degree field, and the new HD, the angio unit, claims to have a 140 degree field. So basically in just 4 swift moves, one can picture the entire retina. Some of these newer imaging techniques are not that new, like angiogram, but its usage in different clinical modalities are new. This, for example, is a disease that has been injected, doing well, and now has a recurrence. So you don't need to be ophthalmologist to understand that this area has not got perfused, and only the white area is perfused. And there's a lot of it leaking here, which means that this is bad blood vessels, or neovascularization, or bad neovessels. So unless you treat these, unless you recognize these, it's going to be a problem. Now look at for a moment, don't look at that dazzling black and white picture, but look at the top left. This is a very innocuous looking retinal picture. This baby has been injected in a state. The child crossed over to another state. That other state did the laser. This child is now 14 months old, one-eyed, by which I mean the other eye had gone into a stage 5. So this is the child's only seeing eye, and even there the vision is low. Now when you look at it, it doesn't look too bad. Only I'm talking about the picture on top. Yes, there is some laser that needed a little more laser, but remember this child is now 14 months old, injected and lasered almost a year back. When you do the angiogram, what you see here is the disease is still active. So this is what happens with incomplete treatment, and if you don't follow up these babies right enough, the vision in this so-called seeing eye was also very limited. And unless, of course, at 14 months, we cannot do the laser under topical anesthesia, so this child had to undergo general anesthesia or sedation, but we had to complete it to restore the normal vascularization and then improve the vision through vision stimulation. One of the newer imaging devices that we are using, which has been tremendously used in adult retina, but is hardly used in pediatric retina, is the OCT. And I mentioned a bit of that making its entry into the new classification. So this is a publication from our group where we found this swelling, and I'm going to use very layman terms here. This swelling in the center of the retina what we call macular edema of prematurity. At that time, we didn't know what we were looking for because there were no previous reports. But what we found were there were two patterns. Either one in which the entire fovea is disrupted, or a second pattern which is sort of parafoveal, which is slightly underneath the top layer and kind of spreads itself on either side of the center. What we did understand is that both patterns went away when they were related to prematurity by the time the child was 3 to 4 months corrected age. But when we followed up those babies, we found that even though that edema or swelling was transient, it did affect their vision all the way up to 12 to 15 months. So we had to recognize these babies who had some sort of abnormal fovealization. And that's a term which means while the fovea was developing, something subclinically went wrong. And unless you detect that and you understand that these babies may have an anatomical disadvantage and therefore a visual disadvantage, and unless you stimulate them through our vision stimulation department, they will lag behind. And with vision lagging behind, other milestones will also lag behind. Because as we know, a majority of the learning in the first year of a baby, 85%, comes from vision. We were then interested in seeing how these layers, or rather the lack of it, or the delay of these, can actually code for vision. Again, the names are not important, but this is a OCT of a preterm baby seen after a few weeks of birth. And what we noticed is this blue arrow is when the layer inside and on top have not fused, which it is supposed to in a normal adult. So if it doesn't fuse, or if there's a delay in fusion, if there is a delay in this space happening, if there's a thinning out of this line here, which I'm marking, or if there is some absence of some other layers, all of those can actually code for poorer vision. And remember, these are all, otherwise when you look at the retina, you say it's normal, because it is normal. But these are subclinical findings that we find out. So as our ability to image these retina using different tools improve, we are able to figure out better things. This, on the other hand, is another step forward. It's OCT angiography. The angiogram picture that I showed you first is an invasive procedure in the sense that you have to inject a dye in the vein and then image the baby or the adult using a special excitation and barrier filter. What if you don't want to use the dye? So there is this device called OCT angiography, used again extensively in adult retina practice, but I think we were the first group to report it in a baby. So what we are seeing here is that what we always believed to be blood vessels, abnormal blood vessels sitting on the retina, actually have a deeper extension. And unless you take care of those deeper extensions through treatment, they are not going to regress. You have to be aware of it, and we are now imaging this for the first time. We took the study a little further and looked at babies between age 5 and age 10 who had good vision. By good vision, I mean 6, 9 or better, who had normal retinas, and they belonged to 3 groups. Either they never had ROP, they had some ROP that resolved, or they had ROP that was treated. But all of them had 6, 9 or better. Despite having so-called good vision and normal anatomical outcomes, what we found is their deeper foveal plexus on OCT angiography was not normal. So the guys who had ROP had some abnormalities that persisted perhaps lifelong. So there is some subclinical change when we don't know the influence of that as far as their, let's say, their depth perception, stereopsis and so on is concerned. This was one of our more recent publications. It was a thesis of one of our postgraduates where we are examining contrast in babies who are just born using these very interesting, very easy to use contrast patterns. And what was really exciting was the children who had lower contrast during ROP screening had poorer vision at month 3, month 6, and month 9. Therefore, the ability to predict that this child may have a vision problem even while doing their ROP screening, even when they did not have ROP, may be very important as we follow these babies as they grow forward. Now, this is the part that I had actually reserved for ophthalmologists. So I'm going to just skip, and this is going to be like a flip book where you just see a lot of images moving fast. But suffice to say that laser is still the gold standard of treatment. Anti-VEGF has some indications, and I'm going to summarize that in just one slide. And sometimes, even though the disease merits anti-VEGF, of course, some of these cases are in the pre-anti-VEGF era, But even sometimes, when the disease merits anti-VEGF, just from the disease perspective, you may not be able to give it. There are still relative contraindications like higher chances of cerebral palsy. There are issues when there are intracranial hemorrhages, and there are problems when there is a local infection. Because when there's conjunctivitis or infections, you might not be able to inject a drug because the risk of endophthalmitis then increases. At some point, you must realize that even these severe forms of disease that would have otherwise been amenable to anti-VEGF can also be treated using laser. And you don't always have to do the laser so close to the fovea that you think, oh my God, I'm going to obliterate zone 1 or macula. So this is an example of how you can spare the macula, and I'm going to go really fast and just take you to the last picture of this. So that very bad disease, if any of you all could have recognized that to be really bad fibrovascular hybrid form of aggressive ROP, it has completely resolved. This is 3 months after that laser, with a large part of zone 1 and even zone 2 posterior spared from laser. And when these children grow up, they have as smaller refractive errors as probably anyone else that you believed would have had with extensive laser. And this is about less than a single digit. They have -3, -4, -5, and not -18, 20, and 30 that I used to see as a resident in the days that there were different forms of lasers being used then, or even cryo about 3 decades back. But there is a concept called posterior laser, and I want to bring this, even though this is an audience of pediatricians, that is when a laser has been incompletely done, or done well, but the disease has not come down, then you can add laser in front of the disease. There are rules on how much, where, won't get into that today. There's another audience for that. But if you do that and then do the interval laser in between, they do extremely well. So here's another example of a posterior laser. This has been done intentionally in the first sitting itself. So this is the primary posterior as against that one that got referred to you late, which is a secondary posterior. Now this is the traditional teaching where we laser the avascular retina, and then this is all the avulsed vessel. This is the raised part, which is kind of like a retinal detachment, but I won't use that word here. And you add posterior laser here and in between these blood vessels as well, and then you have to come back and do the rest of the laser a week or 2 later. You see how this is completely flattened out, and you see how now the complete fibrovascular proliferation has gone away. When you do a posterior laser, what's the advantage? You have an extremely good anatomical outcome, which basically translates into a great functional outcome. They have a much lesser myopia, they have a broader arcade, and their stereopsis, all of that, it gets better. Not to mention the risk of tractional retinal detachments as further adults also comes down. And this is the final outcome of that baby. There's another time you can do laser when you're buying time, when surgery is either not possible or there's no facility. Now here is a 4A. This is a detachment. But you're going to add laser posteriorly where possible, and sometimes, if you're lucky, this detachment, all the exudative part of the detachment goes away, the tractional portion moves to the end, and we have now a series of about 38 cases, that is about more than 70 plus eyes, where we have not required surgery just by doing laser at a point where everyone thought that surgery was required. Now, this whole laser after anti-VEGF is something that I want you all to understand, because as we go forward, maybe 30% of cases in India are going to be treated with anti-VEGF. So again, for those who have not seen, this will be a very severe form of aggressive ROP, and this is how it looks about 2.5 to 3 months after injection, 10 weeks later. Looks great. The pus has gone, the hemorrhage is gone, the dilatation is gone, but when you do an angiogram, you see how far the blood vessels are from the end of the retina. So this is persistent avascular retina. Remember, this is not a recurrence. This is just, this is not even a reactivation. This is just blood vessels growing on its own, and now the child is becoming older and heavier. So now you have a choice. After the weight of about 4 or 5 kgs, it's going to be very difficult to treat these babies under topical anesthesia. So either you counsel the parent that, okay, look, I'm going to wait longer, but your baby will require treatment months later under general anesthesia, or you might have to do that laser under topical anesthesia earlier. So this, how earlier, would depend on which drug. Broadly, we've heard that there is something called Avastin and Lucentis. Again, these are the trade names, so let's use the generic names here, bevacizumab and ranibizumab. Bevacizumab has a later recurrence. So you will get a recurrence sometimes 3 to 4 months after injection. Ranibizumab on an average has a recurrence after about 1.5 to 2 months. So depending on the drug, and we won't get into the legalities and which one is more suitable and so on for this audience, but depending on the drug, the follow-up pattern changes. This was a publication from the Arvind group, which said that when you find that there is no further growth on 2 consecutive visits, 2 weeks apart, you might conclude that this is where the peripheral avascular retina, or persistent avascular retina is. I'm sorry for the really small font, but this is a suggested protocol from the Indian ROP Society, which we've not still made public. It is still under deliberation. So just accept this as a possible guideline, where we are saying that the persistent avascular retina, wait for the blood vessels to grow at least into zone 2 anterior, or a post-menstrual age between 48 and 52 weeks, or the weight of a baby around 4 kgs, and of course that is surgeon comfort dependent, or no facilities for GA, or, and this is important in India, the last point, parents unlikely to follow up. If you keep telling them to come weekly, every 2 weekly, for months on end, believe me, even the most committed parents are going to make some excuse not to come back. And that's exactly the time, perhaps, that you will have a reactivation, and like that one-eyed child, probably lose the eye. It doesn't make any sense in doing a timely anti-VEGF if you can't give complete treatment. So when anti-VEGF, so these are the possible indications. So nowadays we call it aggressive ROP, so choose it well. So in our institute, we do anti-VEGF for posterior zone 1 or zone 1. If the media is so poor that you can't really do a laser, or if there's very bad tunica vasculosa, either you don't have access to laser, you lack the expertise to do laser, where follow-up becomes an issue, especially this happened during COVID time, and must follow with the persistent avascular retina. Now, this is an important topic for pediatricians and neonatologists, cortical vision impairment. As preterm babies are more amenable to hypoglycemia, neonatal hypoglycemic brain injury, or NHBI, is probably underreported in our country. Neonatal research will show you that symptomatic hypoglycemia has 66% chance of CVI. Non-symptomatic, which is basically hypoglycemia without seizures, still has a 16% chance of CVI. So CVI is becoming now the leading cause of blindness in the West, and unfortunately we are also catching up as our neonatal care improves. And one important thing that you must have in wherever you're doing ROP screening is to have a feeding room, and that's one of the amazing things that I saw at Dr. Reshma's center as well, because the worst thing you can have is your baby waiting for you to screen, and in your outpatient throw a seizure because they have missed a feed. Now, what we are trying to do here is, of course, MRI and clinical examination is the gold standard to diagnose CVI, but we are using ophthalmic imaging, and I'm going to be very quick about this. So that pattern B edema that I showed you that we reported 12 years ago has now been linked to neuroimaging markers of CVI. So we're using this routinely in our center, and we now have treated about 3,500 children with CVI, and I'm told from the department that about 121 of them have gone to normal school, taken out of blind school and gone to normal school. So, and that for us is the measure of success and not anything else. So OCT can sometimes be used as a easy to do office-based tool. I know MRI is simple as well, but this is much cheaper and much easier to do. And this was collaboration work with Duke University, where they correlated these findings with brain injury, both in traumatic brain injury and in CVI as well. OCT is also used to diagnose other comorbid conditions like rubella retinopathy and a lot of syndromes where we can predict that they will have cortical vision impairment. Here, for example, the salt and pepper retinopathy that we all think we associate rubella with, this child came to us without a diagnosis of rubella. No one knew that the child had heart disease or deafness. The child was just a few weeks old, and we were shocked to see we could see salt and pepper retinopathy at such an early age, and then we have reported these very unique findings on the OCT with rubella retinopathy. Down syndrome, almost none of them are apparently, and if you look at literature, none of them apparently get to 6/6 or normal vision, and that's not because of their refractive errors, and not even because of their higher mental function. So what is it that happens? Now, OCT helped us understand one thing, that their OCTs of their central retina was similar to children without Downs in the first 2 years of life. And after 2 years, their imaging started looking more and more aberrant than normal babies without Down syndrome. If you speak to developmental specialists, they'll tell you that neuroimaging follows that same protocol. Up to the age of 2, there are tangles and all that changes that are seen both in Downs and maybe even early Alzheimer's happen usually after the 24 months of age. And we were surprised to read that sort of similar corollary happening in retinal imaging. OCT can also be used for children whose vision does not improve despite giving them the correct glasses, patching, basically amblyopia therapy. This is the right eye on top and the left eye below. The right eye is normal at 6/6. The left eye has never improved beyond 6/18. Now, you don't need to be a retina specialist to tell that this top white layer, which if I tell you is normal there, but here is completely split. So there's something wrong here subclinically. Again, when you look at the retina, everyone's going to say both eyes are normal, but they're clearly not. And that's how you can figure it out much earlier. He raised the issue of predicting, and we have some work which we've done in our lab where we're using the tears of these babies to predict ROP. Firstly, when we first did this study, I was shocked to know that preterm babies can even secrete tears, because somehow we thought lacrimal glands start functioning much later. So whatever it is that we are taking on that very simple filter paper, which is used for adults as well, we then took it to our lab. One second, I just want to show you this video to show you that, and I don't know whether you can see this water column has gone all the way up to 20 millimeters. So 20 millimeters of tear is being produced in a baby who's otherwise undergoing ROP screening, so you can tell the age. We worked on several families of proteins. They are here. Some of them are pro-angiogenic, some of them are complement, etc. And from there, based on the ratio and the age of when we were able to see it in the tears and then correlate it with the ROP that they eventually developed, we've published this first paper which we think can be used as a prediction for ROP going forward, but this is currently only at a lab-based model. But our institute has now created a point-of-care kit. So we have a kit now, and we hope that in the next couple of years we'll be ready to make it available, where it's just like going to be taking an RBS sample, like a prick of blood, and putting it into that machine, and it gives you the report. We should be able to test this in the field, where we are able to take the tears in the rural outreach, take the tear, put it into this kit, and out comes the reading. And from there, able to predict when the baby, if the baby, will get the disease or not. Imagine what a big situational difference it will be for the parents to tell one parent, look, your baby's at low risk, you can come after 3 to 4 weeks, as against, look, your baby's at a very high risk, you need to come back 1 week. So this weekly testing, this two weekly testing, just because we don't know or can't predict this disease, may eventually come to an end, and we hope that future studies will help us do that. I know there's a separate speaker for this, so I'm not going to touch upon this. But this is what created the awakening. On July 1st, 2015, 1.8 crores was awarded for a child who had gone blind. The child was 18 years, so no longer a child, in fact, and it was fought all the way from Tamil Nadu's consumer court all the way to the Supreme Court. And this really woke up both the ophthalmic community and the pediatric community. But more importantly, it has woken up the legal profession. And with that, a lot of advocacy has gone on. We reported this paper where we looked at seven legal judgments that went against, 6 of them went against pediatricians, 1 of them went against the pediatrician and the ophthalmologist. So I think you as a cohort have a lot to lose if we don't follow the guidelines right now. And this is in no measure trying to scare you, but I think the better we are made aware of what we should be doing. The funny thing is, if we don't do what we are supposed to do, we'll be more liable than if we do something wrong completely. So I'm not going to dwell on how we can prevent litigations, because I know there's another speaker for it, but this is available in our paper. After looking at all the judgments, we picked out what could be the best way to prevent that. The Indian ROP Society, under the leadership of all the names you see there, led by Dr. Azad, We started this registered body in 2016, and it's our aim to bring together, right now the membership is for ophthalmologists alone, but we are very much keen to take it forward and make neonatologists and pediatricians associate members as well, because we know it can't work otherwise. Again, a moment of pride for us that as early as March 30th, 2020, we came out with, just when the first lockdown was announced, we were the first society, probably the first group in the world, to talk about modified ROP screening guidelines to be done in the pandemic. And it was followed by all the SAARC nations. Happy to note that because of which blindness continued to be prevented in our rural outreach because of some of the measures that we came out with, and we told them how to do it. And remember, this is March 2020 when we all thought the pandemic will end by June. So some of the guidelines that we brought out was not just a modification in how to change or tweak the screening patterns, but also how to modify the treatment patterns. This might seem like a thing of the past, and I surely hope it is, but it's learning as we go forward. This is me and my teammate trying to, at that time, as you can see the date, it's April, first week of 2020. We had no idea how much of PPE we had to wear, and we literally had to take the permission from the health secretary to go into this rural hospital to treat this COVID positive baby with ROP, but it was learning. I'm going to end with artificial intelligence. It's like the big catchword here, and you know Google and Chat GPT, is it, has probably set to take the world over. What I want to tell you is that I don't think AI is going to take over the jobs of ophthalmologists or pediatricians. It's only going to help us manage these babies better. A few years ago, we started working on machine learning, taking out these images from otherwise poorly gradable images and enhancing their features to be able to make some sort of sense from it. But our real work started about 4 years ago, and this is an independently supported PhD from a lady in Chennai, and there are other groups that we work with, all biomedical engineers, by the way. And this is one of the more recent papers where the diagnosis of that black and white picture that you see here is coming out from her algorithm. And basically it means feed in some images, and the algorithm will tell you stage 2, stage 3, and therefore needs treatment or not. Of course, there are legal issues. Of course, there are clinical limitations. But as we start driving the prices of cameras lower and making technology more available, tomorrow, in a week, a year, 5 years from now, ROP images will be millions every day. And we simply don't have the human resources to read these images unless we have a ready-made AI algorithm to at least triage these images. Okay, needs to be seen by the specialist, completely normal. As he said, there are only 3 outcomes: needs treatment, needs follow-up, completely normal. And the most difficult is the completely normal. Because the moment you say, mother, your baby is never going to get disease, you don't need to come back, be sure that you've signed out that certificate. If you are wrong, your AI algorithm is wrong, God help you. So the success rates of the current algorithms are good, but they're not perfect. They're in the early 90s, which I think is very encouraging, but there's a lot of work to be done, and we are doing it, and there are other groups in India as well. I'm ending with our KidDrop model because I was asked specifically to talk about it. So this has been there since 2007. The idea was to replace the so-called ROP specialists by non-doctors who are capable of taking imaging. We are now at about 144 NICUs in the state of Karnataka. There was one district that was not covered for some reason, and that is also being covered now. We are almost 2.5 lakh babies now since last year, and about 3,600 babies have been treated. A majority of this has been from the rural and the semi-urban areas. What I'm very happy to tell you is that every baby born in a government hospital, we have done free screening and free treatment since the inception of this model. So it's really a cross-subsidy model. Initially, there was support as a public-private partnership from the government where they reimbursed costs of travel, but from 2015 onwards, it is completely self-supported. And this is important to mention because as you take on tele-ROP models in your state, it is not something that has to work on philanthropic models alone. You can make it financially viable by doing free service, and more than 68% of our work is free because the majority of the numbers do come from the government sector. Despite that, we not only break even, we also have some money for our own research. And that's the beauty of cross-subsidy, and I think this can be worked out, and this has been our aim and endeavor to help other states set it up. We used to train on site. Fortunately, we have a whole online training program. Again, got ready before COVID. And that was great. And I've shown this slide before where we are training technicians to have different levels of skill. This is one of our first slides that we ever made in 2007 and 8, and I've never changed it since because the model has remained the same. Take the camera into the NICU, get the technicians to do the imaging, allow them to do the initial triaging, upload the image on a telemedicine platform, the specialist looks at it on his or her mobile phone. And remember, I'm talking 2007 and 8 when the iPhone was the first touch phone. So since then, we've been trying to experiment. Today's touch phones are even better than DSLR cameras. So I think we've helped the fact that technology is now helping us back. And all of this is the very first iPhone, and there was so much excitement in actually zooming and dragging and dropping, something that we take for granted. A very busy slide, but to let you know that every zone of Karnataka state is serviced by a team. Each team visits 3 to 4 NICUs every single day. And we cover about 3,000 plus babies every month. And from there, the cohort of babies that require treatment, initially, unfortunately, there was just 1 or 2 of us treating babies all across the state. But over these years, we've created a cadre of trained and accredited specialists. Only those who require to come to Bangalore come, or of course, we make the trip there. But a majority of them are treated locally. And now with support with people like Dr. Reshma, our babies cross the border from Gulbarga and bordering districts all the way up to Solapur as well. So today we have a coordinated effort, not just in and around southern India, but hopefully across the country as well. This is our on-site training. So we have a training module that they take, a bit of theory, MCQs, FAQ type of thing that they can take at their parent institute. Then they come to us with some hand-holding, first on a mannequin, and then they go back with some other efforts of hand-holding while they are imaging these babies. Then they go back to their parent NICU, and then the rest of the mentoring, if required, is done online. The impact of a telemedicine model is not just the fact that it is getting emulated in different countries, some of them are mentioned here, and different states that we are here, but the impact is the amount of blindness that we can prevent. This paper that we put out a few years ago says that if 10 states that have a big ROP problem in India follow a telemedicine model which doesn't have ROP specialists where you're training technicians, then you will save up to $108 million worth, and you can convert that depending on the dollar rate. This was about 5 years ago. That much of blindness you can prevent. So let me give you our example in Karnataka. So far, 72,200 odd unique babies, 3,667 treated. There's a WHO formula which is called blind person years. Number of babies treated, and remember this is both eyes. So let's just go with that. So blind person years is the number of babies treated and who have got prevention from blindness into the life expectancy, which is continuously improving in our country, into the per capita income, which is also improving in our country. So based on today's statistics, about 3,400 crores of blindness has been saved. And I think it's important to talk numbers, especially fiscal numbers, because this is what will help you get the support of NGOs, of government, of participating organizations, because they want to know, when they talk about a return on investment or an ROI, all ROI need not be, I've put in 1 rupee, I need 1 rupee 20 paise back. It could mean I've put in 1 rupee and I'm getting blindness prevention, and these children are going to grow and serve our country, and they're going to be blind free, and their contribution will have something to do with it. I want to end by thanking all our collaborators, including Government of India, and all the other universities that we work with. Recently, with World Prematurity Day, we had this cutout caption, our children are growing bigger, and she's holding a placard which says, screen before 30 days, prevent blindness from ROP. Thank you very much.
I request Dr. Manjusha ma'am to felicitate Dr. Anand Vinikar sir. I request Dr. Sandhya Ragoji madam to felicitate Dr. Abid Ali sir.
directly चाहिए, इनका भी चाहिए.
Okay. Now we'll have a small, thank you Dr. Anand Manikar sir, it was a very nice informative lecture. Um, other than the preterm babies, we also see many term babies which have ROP. And we have also seen that ROP disease is not only symmetrical, but sometimes we get asymmetry in that. So can you tell few points about term babies getting ROP and the asymmetry of the disease?
Yeah, I think important question there. So term babies developing ROP could be seen, and we've reported that in our universal paper, where I think 16% of babies, and the Chinese have reported it too, will develop an ROP-like ridge. Now, here it is important to differentiate between whether it is ROP or familial exudative vitreoretinopathy, which is a genetic condition that mimics ROP. At least in my state, consanguinity is very high, and we see an increasing number of FEVR cases. How it is different is that if it is ROP, it would usually resolve in about 2 or 3 months. Almost no term baby whom we've seen ROP in has gone up to type 1, that means requiring treatment. But yes, it's a curious phenomena, so we follow it up till it's resolved. If it's FEVR, then it doesn't resolve because it is genetically predetermined, and then one must have to use the FEVR protocols on when to do treatment, including prenatal diagnosis for the subsequent children. Asymmetry of disease is not as uncommon or rare as we thought earlier. In our series, in one paper we looked at, it's about between 5 and 10%, which I think is fairly high because when you think about how symmetrical the blood vessels grow, whenever there is an extreme asymmetry, that is in one eye that is almost looking completely normal and the other eye looking like an aggressive form of ROP, obliteration or otherwise, there we investigate for local factors. In at least 3 cases so far, we have sent the baby for a carotid Doppler. We've looked at vascular perfusion because we believe that maybe the vasculature is compromised more from a local perspective. And we have found carotid stenosis and cardiac problems in these 3 cases, but a majority of cases don't come up with anything positive. So when we see a gross form of asymmetry, we refer back to the neonatologist with a point saying, please rule out any local vascular pathology.
And when you're giving anti-VEGF, you always give it before 36 weeks, 32 to 36 or?
Our preferred age is between 32 and 35.
Right.
After 36, if the disease so demands, then we have relaxed that to about 37, 38. The reason why she asks that is that there is a fear among ophthalmologists of something called a crunch phenomena. So after 38, as they come closer to 40 weeks, VEGF normally drives down in the vitreous cavity, and there's another protein called transformation growth factor, TGF, subform is beta. So TGF beta increases and VEGF comes down. Now TGF beta causes fibrosis to increase. So when the ratio of VEGF and TGF beta get upturned in the favor of TGF beta, traction of fibrosis may increase, therefore worsening the disease and causing retinal detachment as against a normalization of the blood vessels. So there is a fear, and this happens because in adults in diabetic retinopathy, it's reported all the time. So that's our fear, and that fear is true. So one has to weigh how raised that fibrosis is, what is the age of the child, what is any pre-treatment, systemic comorbidities, and so on before we advise.
Thank you, sir. Now we have virtually Dr. Milind Shah sir. So I welcome Dr. Milind Shah sir with a short video, and we will have Dr. Milind Shah from Bhopal. I welcome Dr. Milind Shah sir. He is the director of Naval Maternity and Nursing Home. He is also the director of Asha Kiran Sperm Bank and Infertility Center, Solapur. He is also a renowned gynecologist practicing in Mumbai at Naval Maternity and Nursing Home Endoscopy and IVF Center at Sion. He has been the president of ISO PARB 2016 to 18. He has been the president of IMA Solapur branch in the year 2021-22. He is the founder president of Infertility at High Risk Foundation. He has been the honorary secretary general of FAOPS, that is Asia Oceania Federation of Perinatal Societies. He is the Vice President of FOGSI, Federation of All Gynecological Societies of India. He has been the second Vice President of ISPAT, that is Indian Society of Prenatal Diagnosis and Fetal Therapy, in 2019-21. He has been the Deputy Secretary General of Indian Society of Aesthetic and Regenerative Gynecologists. He is the ex-chairman of Rural Obstetrics Committee of FOGSI in the year 2004-2008. He is the managing committee member of IAGE, ISAR, IFUMAB. He is the peer reviewer for Journal of OBGY of India. He has been the committee member of Asia Safe Abortion Partnership Program. He is the past president of Solapur OBGY Society. He is the professor and head of Department of OBGY Gandhinatha Homeopathy Medical College. He is the national editor member of FOGSI website. He has authored a book, Hypertensive Disorders in Pregnancy, the Pelvic Organ Prolapse, and contributed to more than 20 chapters in various books. He is also a very active Rotarian and a very humble person too. I welcome Dr. Milind Shah, sir.
Thank you very much, Reshma. It was really a mesmerizing introduction, and I don't have a word to say thanks, but really a great effort you had put in for this particular CME. I apologize for the same, the inability to come in person. In fact, I had booked my ticket for from Bhopal to Mumbai yesterday, but because of some problem, I could not travel back. But when I was listening to Dr. Anand, I realized yes, a lot of things can be done from the ophthalmic point of view, but at the same time, we also need to do a lot of things per se antenatally as well. I'm going to just show certain slides which are not actually the slides per se, the pictures to coordinate what actually happens in the antenatal clinic when it comes to the blindness or the severe visual impairment. Can I share my slides, Samendra? Just try whether it's seen. Yeah. Are you able to see my slides?
Yes, sir.
Okay. Now let me put that on the yes. Are my slides moving now?
Yes, sir.
Acha, great. Yeah, good. So friends, basically, it's very aptly said by Atul Gawande, our own Indian settled in US, that our great struggle in medicine nowadays is not just with ignorance and uncertainty, which very commonly happens in the obstetrics, and also the complexity in how much you have to make sure that whatever you have in your head and you think about, there are thousands of ways where things can go wrong. That's what actually we noticed as well in this last 2 years, where we never thought that this pandemic is going to create such a havoc in our actually the practice as far as the health of the patients as well as the women is concerned. I still remember all those unfortunate women who were COVID positive and were unable to get the proper services. And of course, there were certain issues related to the antenatal care as well. Now, friends, with this, I remember two actually the stories which came in my own practice as well in last 30 years. A story of Dr. Aruna. Dr. Aruna actually got a rubella infection in pregnancy, and the baby was born with congenital cataract. Though she was doctor, and when the screening was done at 24 weeks, hardly anything we could have done for that particular case, because you know the rules of the various termination of pregnancy or the other law other concern. Similarly, another lady I know, the Manda, who comes from Raichur, who had got developed a preeclampsia, and when she used to come to my clinic, we used to give her antihypertensive to control her hypertension. But every visit, we used to find that there's no much of the response. And eventually, when the baby was IUGR, growth restricted, and we needed to deliver the baby a little early, she told at the end of the day that yes, she was not taking any medicine because she was told by the local family physician that there is no need to take those medicines. And when the baby was born, baby was having the severe visual impairment. Manda realized that quite late, but then I thought, yes, we need to do certain things to dispel all these myths related to the various issues in the antenatal care, and same is applicable to the blindness as well. Because all said and done, we always think that it happens actually only more in the poor or the low socioeconomic strata, but not necessarily, because these two stories which I told you were from the very affluent class, but for variety of reasons, there were actually problems which we saw there. They got the visual impairment in their babies, and that's why one need to do certain things which are really important to see that everything goes proper to avoid this blindness or avoid this severe visual impairment in the babies. Friends, we know that it starts from the conception itself, when the sperm and ovum unite, because we know there are certain things which are hereditary. It could be a familial cataract, it could be the retinal dystrophies, it could be, though rare, a retinoblastoma as well. Same way as the pregnancy advances, the various infections play a role, the rubella as well as toxoplasmosis. And if the woman is having the vitamin A deficiency, there's every probability that the baby as well may get the deficiency if not corrected. At the time of birth, the retinopathy of prematurity, which is very, very widely discussed from the pediatrician point of view, medical legally, as well as the ophthalmic point of view in this particular CME, which I'm not going to touch upon. The newborn conjunctivitis, again, a very common cause where we need to intervene very effectively, suppose we find that, because quite often this infection can be acquired in the vaginal canal as well. And we need to see all those factors during childhood, because quite few of them, they definitely come to obstetrician suppose they get any problem. And in that, what is most commonly seen is the traditional eye medicines or the injury which happen because of variety of reason. Now, coming to vitamin A deficiency, in our country or many of the Asia Oceania countries, it has been found that women of reproductive age should not receive large doses of vitamin A, which is contraindicated in pregnancy. But if we can correct that before, suppose we find those beta spots, definitely it's going to create a change. But when it is seen, we need to immediately after birth, the child need to be given the 3 doses of vitamin A on day 1, day 2, and day 8. And we'll have to see that there is adequate vitamin A secreted in the breast milk for the newborn baby to avoid all those actually the aftermaths of vitamin A deficiency. The most commonly seen thing in our practice is this harmful traditional eye medicines, because whenever baby gets red actually conjunctiva or redness of the eye, the first thing the grandmother tells about all those herbal things which they can do, which could be the milk, which could be the some juices, maybe some leaf actually they want to crush and put in the eye of the baby. And all that gives us a lot of pain when we see that in front of us. We all the time tell actually our patients in writing, in counseling, through our neonatologist friends as well, to avoid these particular things. But in spite of that, we see that it's very actually common in older days compared to the current era, but it is not uncommon as well. I still remember a story of my own auntie who is now 88 years old, but when she was very young, my grandmother had put certain medication in the eye and she got the opacity in the cornea. So friends, we need to tell all our rural women, because we need to cater more of those under-resourced setup where still these things are more actually empowered by the women, and they utilize those medicines without any fear, and they always feel that that is the correct remedy for that all redness and all other things. It is very, very commonly seen with many other conditions, the obstetrics or the postnatal period as well, but it creates a lot of actually the visual problems, a lot of social and developmental issues as well when it comes to the growing up of that particular baby is concerned. The conjunctivitis is the similar thing which is very, very commonly seen in the obstetric practice. Now, people think that it's only vaginal canal. But you know, friends, when we work at the various centers, we realize that even bathing of that particular baby also could be the cause of that newborn conjunctivitis. Because I've seen that many clinics use the bath, the tub, what they use for the baby bath, which they don't clean properly. The attendant is not much aware about it. and it leads to the conjunctivitis. At the same time, the very commonly seen infections like trachomatis, chlamydial trachomatis, or gonorrhea, they also can be a cause of that conjunctivitis. And immediate opinion of the ophthalmic surgeon or the pediatrician need to be addressed to see that we get a good actually treatment of that particular infection, ophthalmia neonatal. It is essential to treat the both parents as well whenever we diagnose these particular conditions, because we know that how that infection has occurred in that particular couple because of the sexual activity as well. The congenital cataract, again, suppose diagnosed early, detected early, definitely can give a good outcome in that particular given baby. And so referring that particular baby timely to the ophthalmic surgeon is very, very important. The very commonly cause, as we see these the mainly infections which are there in the antenatal period, commonly seen are the toxoplasmosis and the rubella. Nowadays, there's a lot of awareness. Quite few of us, we do a lot of activity in the adolescent girl to vaccinate them for the rubella, to find out whether they got the immunity for that particular infection. And even the girls in the colleges as well as the schools are aware of it. And that's why slowly now we are getting quite good decline in the rubella infection in pregnancy. Quite a few clinics even do routine actually the IgG levels of the toxoplasmosis and the rubella to realize whether that particular lady is immune to those particular infections, to avoid all those problems related to those infections. It's not only eye, we know that many other organs can get affected. A very commonly affected organ is again the heart, which is leads to the very many congenital heart diseases as well. And that's why one need to address our society on that. We need to have a good liaison with everyone. It is not only the obstetrician, pediatrician, or the neonatologist or the ophthalmic surgeon, but the nurse and the attendant and the family member and the counselor. All of them, they can play a major role. Quite often we see that these women get actually more affected by the advice which is given by the senior ladies in the family rather than the doctors. And that's why we always and always see that the counselor addresses this particular issue very effectively. I have actually started this practice in my own setup as well, that we appointed a certified counselor who has done her PG diploma from symbiosis after her graduation, and she helps me not only for such counseling where I feel as a busy practitioner we are inadequate or we are unable to give the sufficient time, or maybe my staff, other staff is busy and inadequate to give those addresses. But all those related issues, could it be infertility, could it be a postnatal care or the lactational advice, the wonderful job is done by a designated person who looks after this particular issue very effectively. And I'm really thankful to her for all that work which gets quite real, and we can concentrate more on the other work as well, because counseling is an art. And all said and done, we never understand what is happening behind the curtain in the families of our pregnant women. Quite often they don't realize what is happening, and we realize it quite late as well. The congenital glaucoma also can be diagnosed, and immediately the anti-glaucoma treatment can be started. But again, delaying from our side to referring that particular patient to the ophthalmic surgeon can cause a lot of problems as well as the visual impairment is concerned. The congenital tumors like retinoblastoma, yes, quite often they do surgeries, or sometimes even inoculation is required. But again, a timely referral and intervention is very, very essential in this particular patient. Yes, this is a chapter of its own, actually, the kind, and I'm very sure all of you must be aware of all those things which are related to the retinopathy of the prematurity is concerned. It is not only prematurity. Now we need to have the newborn screening for all these actually problems which are seen and diagnosed timely, can definitely lead to the good outcome as far as the life of that particular, or the uh, future, actually the upbringing of that particular child is concerned. It's very routinely observed thing in newborn screening in the obstetric practice now. We always and always see that not only the eye care, but also we see for the visual, the hearing impairment, we screen actually all those particular babies for the all those analytes which are very commonly seen in that particular area, especially in our actually country or in our area, which is in the we can call the rest of Maharashtra and the Karnataka. We commonly screen actually all those particular babies for the J6PD disease, galactosemia, and the congenital hypothyroidism and congenital adrenal hyperplasia. Quite often, people feel that it's very difficult to assess the visual actually the function in newborn babies. But I'm very sure Dr. Reshma is going to put a good light on that particular thing, as there are so many advances as far as the that screening is concerned. And I'm very sure all those new gadgets, new advancements need to get percolated to in grassroots level to the rural women as well, to see that they get proper address to that. The prematurity can be prevented by variety of means. Now we have a very robust actually screening available in the obstetric practice to diagnose premature labor as well as to treat premature labor. Previously, we had a thrust on certain tocolytics, but now we have an oxytocin receptors antagonist available with us, which can be effectively used, and we can prevent that particular premature labor as well. But story never ends with the medicine and diagnosis only, but also again, as I told you, the certain social issues which we very commonly see. You know, friends, a very common practice whereby we know that they do the baby shower. What they call in our actually belt the kupsa in Karnataka, because we get a lot of Kannada patients from the nearby district, or in Marathi they call chori. You cannot believe that quite often they undergo that particular function in the morning, and the patient comes in the evening either with premature labor pains or with premature rupture of membranes. And always nowadays counsel them that you'll have to take a good care to see that this function, if you want to observe, you'll have to observe that in a limit. You can't make that particular lady to undergo a lot of stress because of that particular function, and it is creating a lot of actually change in the society as well. Quite often I tell them that instead of observing that particular function so magnanimously, you can do the naming ceremony in more better way or the graceful way to avoid all those particular problems. And now people are understanding that particular concept. Especially I've seen the in Karnataka, this particular function is done where the lady sits for entire one day. So many relatives come and so many people, they keep on enjoying that particular function, but the lady suffers a lot, and quite often she gets the prematurity or the premature rupture of membranes, which we can definitely avoid. And I think that everyone can take part in this particular counseling as well, which is very essential. Friends, people always feel that the delivery is very easy process, but we know that it's not very easy. I really don't know whether this video was seen on the screen, because quite often on the visual presentation, the videos don't run properly. But we have realized, yes, a lot of things can be done in the antenatal clinics as well. A lot of actually changes we can create in the society as far as the good antenatal care is concerned, good diagnosis of all those prevailing conditions which can lead to the severe visual impairment or the blindness, and a lot of issues can be handled very effectively. I'm very sure that this particular CMA is going to bring a major change as far as the visual health of that particular newborn baby is concerned or the childhood blindness is concerned. I must say big thanks to the Indian Medical Association and all the office bearers for giving this particular opportunity to speak with you all. And also a big thanks and a very humble sort of apology, Reshma, that I could not come in person to deliver this particular talk. In fact, many studies I wanted to present, but I got stuck up because of some reason at the Bhopal, and I could not travel back to Solapur. But I'm very sure this the function will be a great success and will bring a major change in the newborn care as well as the avoiding childhood blindness. Thank you very much for the patient listening. And if there are any audiovisual hinges or the audio issues, please thank you very much for bearing with me. Thank you. Thanks a lot. Yeah.
Thank you, sir. Thank you, sir. It was a very nice lecture, and take care during the antenatal care, especially to prolong the prematurity and to increase the birth weight of the baby so
Yes.
as to avoid ROP. Thank you so much.
Thank you.
I welcome Dr. Sandeep Kulkarni sir through a short video, and we him, which
Recording
is more
stopped.
important with the medico-legal implications regarding retinopathy of prematurity. Dr. Sandeep Kulkarni sir. I welcome Dr. Sandeep Kulkarni sir. Dr. Sandeep Kulkarni has passed his MBBS and MD Pediatrics from VMMC Solapur. He is a practicing pediatrician since last 23 years. He is the director of SPAN Critical Care Center Private Limited. SPAN is a hospital which has 120 beds for pediatric and neonatal care. He is the PG teacher and a guide and has been a postgraduate guide for many students. He's been the trainer for NRP and FGM course. He is also an instructor for PALS. He has been the past president for Solapur Academy of Pediatrics in the year 2001. He has been the president of NNF Neocon in the year 2002. He was the organizing secretary for Mahapedicon in the year 2015. He has held the post of Vice President Maha IAP in the year 2016. He also has special interests in neonatology and hospital management. I welcome Dr. Sandeep Kulkarni. Dr. Sandeep Kulkarni, sir.
For the nice words. First of all, let me thank IMA Solapur, Indian Academy of Pediatrics Solapur, and Ophthalmology Society of Solapur for welcoming me and asking me to deliver this lecture. Definitely, it's maybe one of the important lectures because we are going to face many such problems in future if we are not that vigilant. So we'll go through these slides. For introduction, like ROP is leading cause of preventable infant blindness in the world. And India, unfortunately, has highest number of premature babies born worldwide. Large number of babies require screening, but very small number of ROP specialists are there in India. And good clinical practices, proper guidelines, and awareness is the need of our to prevent ROP. As Dr. Abid said, this is a third epidemic. So nowadays, because of good care, premature care, babies of premature care, and good NICUs coming out everywhere, the number of premature graduates are there in large number in India. So number of visual loss due to ROP in India is twice as compared to established countries. The higher rate attributes to three factors. One is high preterm rates. Second is suboptimal neonatal care, where even mature infants are at risk. And inadequate number of ROP specialists and screening program. Annually, 3.5 million premature require ROP screening, and approximately only around 20,000 ophthalmologists do screening, and just 2,000 odd are vitreoretinal specialists who manage ROP. So, as I said, for pediatricians or neonatologists, it is not their choice that they have to treat preterm babies, they have to manage NICUs and all. So, it's not their choice. But ophthalmologists, it's a choice to go into this practice of ROP screening because many of the ophthalmologists go away from doing ROP screening. But the need of our is we need more and more ophthalmologists who go for screening and who go for managing ROP. The medico-legal aspects, as I said, as Dr. Vinekar also showed about this landmark judgment in 2015 made by the Honorable Supreme Court of India held the tertiary care public hospital liable for a child who went blind due to stage 5 ROP, and the compensation awarded was 1.8 crores. So this is a very huge amount as compared to many others medical legal cases which were done at that time. So there are other cases too, like in Mumbai case, it went against pediatrician for failure to inform the parents about ROP screening. It detected the stage 5 ROP 7 months after the birth, and 5 lakh was awarded amount for that case. And the main problem was there was document referral of timely ROP screening eyes within normal limit. So whenever ROP is done, ROP screening is done, you can't just mention within normal limits. You have to mention the clear diagnosis of the stage and whatever it is, and then you have to ask about the follow-up also. And in this case, documents were not, they were very faulty, and details must be recorded. The other cases like which went in Ludhiana in 2012, which went against the pediatrician again, failure to inform parents about ROP screening. So it's a need of our that the pediatrician who are managing neonates in their NICUs, each and every child, each and every parent has to be informed about ROP screening. As I said, even mature babies can have problems later on. So one screening before discharge is a must for even mature babies, but definitely for premature babies, as Dr. Abhidari said, 1, 2, 3, 4, it's a necessary thing. So in this case, ROP stage 5 was detected 4 months after the birth, and 7.5 lakh rupees was awarded for that child. The one ROP screening done at day 8 said no ROP in this case. So again, ROP should not be screened very early, where you can't definitely give a diagnosis. And even if it is screened early, they have to call for follow-up again, and you can't say no ROP at day 8. In Chennai, as I'm going to go in detail about this case, and the other case was New Delhi case in 2016, which went against pediatrician and ophthalmologist, where alleged negligent care of premature babies, casual approach, and improper ROP screening by ophthalmologists. So both pediatrician and ophthalmologist were held guilty, and 64 lakh prize was awarded. Ophthalmologists can also be held liable for documents who screen how to screen the drugs which were utilized for dilatation of the eye pupils, and detailed anterior and fundus findings should be noted, and follow-up again has to be mentioned. So these were the pitfalls in that case. In Indore 2016 case, it went against the pediatrician, alleged too much oxygen and improper care of twins. 44 lakhs plus 6% interest for 23 years was awarded, and which amounted to 1.2 crores. Again, the pitfalls were referral on timing, referral was not done at the time, and according to the prevailing guidelines, and oxygen details were not mentioned in the paper. So again, maintaining the paper is a huge task. Nowadays, we know we are all going towards NABH accreditation of the hospitals, but we have to be vigilant about maintaining the details about the treatment, and especially oxygen therapy. In Chennai case, it was a 1250 grams 29-weeker born in 1996, admitted in tertiary care public hospital NICU for 25 days. 4 months later, during routine vaccination, was accidentally detected to have stage 5 ROP. Complaint was lodged in 1996 itself in National Consumer Forum. 13 years later, in 2009, the judgment was given with 5 lakh compensation. In 2015, the case was again continued in Supreme Court, where in 2015 the Honorable Supreme Court of India compensation was enhanced to 1.8 crore. What was the jurisprudence was absence of disclosure in discharge summary for timely ROP screening or proof of preventive care taken for ROP during the stay. So this was the main crux. Second was absence of proof of advice to visit the ophthalmologist for screening. So this was a part which has to be handled by pediatricians. It has to be mentioned on the paper properly. We will go ahead with that how to do it and all. And the compensation which was calculated according to the financial loss, pain and suffering undergone by the patient, and something called restitutio integrum, that is the value of the child, as sir said, it is calculated in many aspects. If the child would be normal at that age with her normal vision, what was her value, and that was calculated according to that. And the calculations were like past medical expenses, future medical expenses, plus compensation of mental agony, lifelong dependency, plus 6% interest. So all this put together, it was coming to 1.8 crore. Potential legal touch points. Now, for the pediatrician and neonatologist, what are the pitfalls which are there right now? One is there is no established screening program in NICU. So every NICU may have a different protocol which has to be standardized and which should go in hand with ophthalmologist society, which they have the standard protocols, and we have to mention the protocols in the memorandum of understanding with the ophthalmologist. See, all these babies will be screened. You can't say that the ophthalmologist, pediatrician can't say that this baby is more than 2 kg, so I'll not do screening. It has to be a protocol based, and we have to mention the protocol, and we should see that every baby is screened at least once before discharge. Delayed referral for ROP screening, again the same. We have to mention the date, specifically when to come, where to come, how to come, with feeding protocols, and installing the drops, waiting area, and everything has to be mentioned again. No follow-up appointments for screening. Many times, it may be not fault of the pediatrician. He might have mentioned it in the discharge summary or follow-up summary, but it has not been explained with details, or it has not been explained with that passion that this has to be done. So the parents take it very casually. नहीं, आपने बुलाया था, लिखा तो था, मगर हमने सोचा कि शायद हम नहीं आएंगे. तो it has been taken very casually by the parents. It has happened many times. So no clear education of parents about implication of failed screening is very important. Protocol and documentation of oxygen supplement used, if it is not mentioned on the paper, again it can cause a huge problem. Regarding ophthalmologists, improper, inadequate or inappropriate documentation. Again, it has been mentioned that you have to have an ROP card. You need to mention the exact stage of the disease, and there is nothing term like within normal limit, no ROP, such terms should be avoided. No appointment or counseling about follow-up screening. Again, the follow-up, as sir mentioned about the date miscalculations can happen. So it has to be mentioned very clearly. Sometimes it has to be written in Marathi or Kannada if the patient is really coming from very rural place. So they have to be mentioned about the date particularly. Failure to treat on time or inadequate treatment, and failure to explain about ocular comorbidities and need for a long-term follow-up. Long term is very important because sometimes the baby has to come again and again for months together. Barriers for parents. One is definitely lack of awareness. So once the child is born, they just want male or female. They just want babies healthy. And they want to listen for pediatricians that sab acha hai. And in that term of sab acha hai, baby is fine, they take it for granted that everything is fine. Whereas there are almost 80 diseases which can't be diagnosed on day one of the life. So these diseases have to be monitored, maybe in future coming months, maybe in years, and sometimes they can come prop up later on. So before telling the baby, the parents that everything is normal, we need to be aware, we need to give them importance of follow-up, even for other pediatric conditions like cardiac conditions and all. But for particularly for ROP, we have to be, we should make them aware. Distance to screening center, again a very big problem, because nowadays from coming from a very rural place, they have to travel maybe hours together, and they don't have a place to stay in city. Neither they have some going back again to their village, it can become a problem. So many a times when the babies are coming from rural area, we ask them to stay for one day in our hospital. Stay for one day, next day they can travel again back, because after procedure again we can't send the baby immediately to through some travel discourse. Cost of traveling and treatment and stay, again it is a big question, because still now government setup has not yet come up with any particular. Now Kidrop is doing a great job in Karnataka, but there should be something in Maharashtra also, maybe Midrop or something like that. But it's really need of our, that we need, our government should be shaken up for this thing. Others like gender bias, definitely more preference to a male child. Who should bear the cost? It's a very big issue from maternal side or paternal side. For everything, these smaller things which we face daily are really important. Lack of insurance for the child. So child's name has not been entered into the insurance or whatever they have. So again, they will ask about ki, if you have to do this, who is going to bear the cost again? And blind beliefs, as many things go in that. So what are the need of hour, that is for screening? One, it should be a good scientific, legibly recorded written documentation. So it should be recorded audially or audio visually if possible, but written documents are very important. So the screening, before screening, everything which we speak to the parents has to be recorded. Draw diagrams for zone, stage, plus disease, whatever, and avoid abbreviations. So we have to write in full form. Write complete diagnosis for both the eyes, and describe aggressive posterior ROP or associated findings whenever applicable. So it has to be mentioned on that ROP card as well, and whatever IPD, OPD paper we have. Retinal photographs will further support the diagnosis, and images can help to educate the parents and will enhance the follow-up compliance. So whenever the parents have been shown the figures of pictures of the retina, they are more interested rather than just on paper. So it is better to have retinal photography for every child, and it remains as a record with us also if in case it goes in for medical legal case. Discharge from NICU, there has to be a separate ROP screening record with findings, follow-up dates, need for long-term follow-up, address and contact number for follow-up on an ROP card. So it has to be mentioned when the baby has to come back, what is the date, what is the place it has to come back, and what form they have to bring. The baby को feeding देना है, नहीं देना है, आने के बाद क्या कर रहा है, drops will be installed, and all those things has to be mentioned. Communicate treating neonatologists. So when the baby comes for follow-up, we have the ophthalmologist has to communicate the treating neonatologist about the finding and comply with the record keeping policy of NICU. So once the baby comes for ROP screening, ideally the baby should also visit the neonatologist who has been treating the baby. So the record can be maintained in both books, like in the ophthalmologist book also and in the pediatric book also. which has to mention the ROP diagnosis, weight gain, weaning of oxygen or anemia of the baby, thrombocytopenia, sepsis and other risk factors have to be mentioned in this paper. Obtain and maintain good professional indemnity cover. It's a need of time. So we have to maintain a good, and it has to be maintained. We just, many a times professional indemnity is done, but the renewals are not done every yearly, and we may face some problem. Now regarding treatment, the treat ROP based on most current recommendation respect to the timing and stage. So every year or every 2 years, there could be different recommendations. As Vinekar said, sir said, that there are recent advances, many recent advances are being done. So treat according to the recent recommendations. Detailed oral and written consent is must. Explain the procedure, possible need of supplement therapy, possible need of even admission after the treatment, type of anesthesia, systemic or ocular outcomes after the treatment, and need of follow-up. Documentation, document this communication, everything on the ROP card, IPD and OPD paper. Treat in presence of a neonatologist or a pediatrician, anesthetist with emergency kit. So baby may land up with hypoxia or hypoglycemia, or maybe sometimes the baby may need a respiratory support in the treatment itself. So continuous meticulous monitoring of vitals, hypothermia, hypoglycemia and pain management has to be done. Pre and post treatment retinal images for documentation and parent education is must. So they are interested definitely. As a parent, the parent will be interested कि ये treatment दिया है तो उसका कुछ फायदा हुआ कि नहीं. So they need to be shown the pre-treatment and post-treatment images of the retina. So summary, awareness is the very important aspect which many in many centers it's lacking. So awareness amongst the pediatricians itself, that we need to screen the baby in the NICU itself, and we need to follow the some protocol according for the neonatal screening. Ophthalmologists definitely need to be aware that ROP, see, I can't expect every ophthalmologist to do this screening, but at least those who are doing the ROP screening, they need to be, they need to be recognized, and as far as possible, we should send the more of the number of babies to such ophthalmologists who are doing the ROP screening. And also awareness amongst the parents, it's very important. So we have to speak a lot while discharging the baby or during the neonatal treatment and all. Documentation of that is like ROP card, or documentation of every finding in IPD, OPD paper, audio visual recording if it is possible has to be mentioned. Retinal photography, pre and post treatment are also very important, but every screening you need to have, if you have retinal photography, it can definitely save a lot, not only for us from the legal issues, but for the parents also. They can save a lot of money later on for the treatment and all. Follow-up is very important. It's a keyword for ROP screening. So we have to mention about follow-up in details. Treatment according to the most recent recommendations, very important. Professional indemnity, we have to do it on both the sides, ophthalmologists and pediatricians. And need more ophthalmologists to carry out ROP screening. It's a need of our. Thank you very much.
Thank you, sir. I ask upon Dr. Raghoji madam to felicitate Dr. Sandeep Kulkarni, sir. there is one question. Many parents, they ask, why does my child or my baby need repeated follow-ups or repeated examinations, eye examinations? Why is that my baby is only requiring repeated eye examinations? So if we tell them asa hai, they will not believe or they will not be that serious. But if the pediatrician tells them, they feel very nice.
Yeah, actually, what is mentioned that the baby is with pediatricians maybe few weeks, maybe a month or so, and definitely he or she has a nice rapport with the parents, especially the mother. So we keep on telling about many things of the baby's upcoming, maybe complications and all those things. But many a times it is our duty to mention about the ROP screening, and those babies who are really sick or who needed ventilator or who needed other gadgets and oxygen definitely, we have to mention them that this child. So it may be as you said that some parents ask about this, why my child. So it may be a fault from pediatrician side that he or she has to mention about this repeated follow-up for the retinal treatment, because they will ask.
And the severity of the disease.
Severity of the disease. So we have to mention during the NICU stay itself that you are going to require for repeated follow-up. And it is not like one baby, we have to do it for many babies. But if the baby is having some disease, definitely it will require. So I think the thing should come from us to the parents rather than ophthalmologist telling him, telling the baby. It has to be our duty.
And sir, another thing in the NICU, when we reach, so many times it happens that the baby is not dilated. So sometimes we wait why it is not dilated. So it is very important to write the time of dilating drops and also how many times it is instilled, and at 10 minutes apart or 15 minutes apart, and which drop. So sometimes when we go, we see that it is not Tropic Acid Plus, but it is either the anesthetic drop or the antibiotic drop. So the sister has
It has to be mentioned on the paper.
Yes. So otherwise the ophthalmologist or the technician will say the pupil is not dilating, I will come next time. So if the ophthalmologist or the technician comes next time and 15 days, and if it is AROP missed, the child may go blind.
We can
so
do
dilating
for
drops,
that. For that, we can do small paper, small paper, and we have to mention the drops, and that has to be attached to the paper itself.
Okay.
And we can just put a sticker on that. So these drops have to be installed, and the nurse can be given that instruction according to that.
Most of the times either they put the anesthetic drops or antibiotics, so the pupil is not dilated.
Right. And one more thing is that, as sir said, if even after putting the proper drops, if the pupils are not dilated, there could be some other disease. So that
there is a disease,
Yeah,
yes.
so
we have to be very, very careful.
Careful about it.
Thank you, sir.
I welcome Dr. Reshma Mehta ma'am. She has done MBBS in batch of 1991. She has done MS Ophthalmology in BJMC and secured gold medal in Pune University for her batch in 1999. She has done the lecturership at ARMCS Solapur and VMMC Solapur and has experience of teaching for 16 years. She has done pediatric ophthalmology at Arvind Eye Hospital, Madurai with Dr. P. Vijayalakshmi, which is her chief mentor. She did pediatric ophthalmology fellowship in 2008-2009 under Dr. Parikshit Dutta at HV Desai. She did ROP screening training program under Dr. Rajwardhan Azad and Dr. Sucheta Kulkarni at HV Desai Hospital in year 2009. She went for training at Narayan Netralaya, Bangalore with Dr. Anand Vinekar for screening and imaging. In 2010-2011, she started screening at Pandarful NICU, and this rural NICU data was submitted to Site 7 Delhi for 3 3 years. She started screening at NICU at Span Hospital, Sangola, Mangalweda, Tulzapur, Usmanabad, Barshi, Umargaon, Karmada and Kurduvadi. Hence she is trying to screen more and more neonate in interior of the Solapur district. So as to prevent any neonatal blindness, her special interest is to treat strabismus, doing squint surgeries and treating amblyopia. I welcome Dr. Reshma Mehta ma'am.
Thank you, Dr. Ashish, for the introduction. I have a few cases which are compiled. They are all rare cases. These rare cases which we saw during our ROP journey. So this was a case of nevus. It is an epidermal nevus syndrome with ocular abnormalities. There is poor development of the left eye and choristoma of the left eye, fleshy overgrowth over the left eye, and there was a huge swelling over the scalp which was excised. There was frontal bossing and undescended testis. There was maldevelopment of the left eye, and the fundus examination was very difficult. We could just see the peripheral fundus, and right eye was also, there was also sclerocornea. The next case was optic nerve hypoplasia, where the MRI was normal. This is a case of congenital optic nerve anomaly, where the number of optic nerve axons in the optic nerve tract are less, the disc appears small. The right side picture shows the normal fundus, where the normal disc size can be seen, and the left side picture shows the small disc. So this was a case of optic nerve hypoplasia. The patient was followed up for 1 year, and the patient had nystagmus, bilateral visual loss, abnormal pupillary response and strabismus. You can see definitely the size of the disc, which is very small in the right side picture. This was diagnosed at day 20 when we were screening for ROP screening. Then we had this case of lipemia retinalis in a 45-day-old baby. He was a first product of second degree consanguinity. The father had history of hyperlipidemia. The baby was full-term normal delivery and was presented with breathlessness, vomiting and loose stool. And this was the fundus picture, which showed light pink colored vessels, and the optic disc appeared pale, and there was pink background in the peripheral retina, and the blood vessels looked milky white. So this was lipemia retinalis because of high levels of serum cholesterol, serum triglycerides which were 14,000, serum LDL which was 300, and HDL which was 90, which is almost 300 times raised than that of normal. But the child is still doing well with Dr. Sandeep Kulkarni sir, and the child is on statins, maybe almost 6 to 8 months now. Then we had this, we usually see these retinal hemorrhages, which are intraretinal, preretinal and subretinal hemorrhages. Again, they can be because of bacterial meningitis, CMV, respiratory distress syndrome, anemia, at most common during birth delivery trauma, either because of forceps or difficult vaginal delivery. Then there were few cases which we saw during ROP screening were congenital cataract, which are doing well after surgery. Then there were 3 cases of retinochoroiditis, toxoplasma retinochoroiditis, where we saw the fundus had hazy media, vitritis. There was an active lesion. It showed, the fundus showed signs of inflammation. And on consultation with the pediatrician, we could treat well because they gave him pyrimethamine, sulfadiazine, and those which were difficult to treat were also treated with leucovorin, and the vision was restored. We had 1 case of retinoblastoma which we referred to Dr. Santosh Honawar sir. This patient had a peripheral retinal swelling, and after every 15 days when we would screen the baby, we could see the increase in the size of that white mass. Then we've seen many of the iris colobomas and retinochoroidal colobomas. Another cherry red spot is very commonly seen with metabolic storage disorders. Then this is a 4-year child which was a stage 2 ROP and now has come with unilateral high myopia. Left eye is good. Another is capillary hemangioma. Bullseye maculopathy, this is concentric rings in the macular area, usually seen in neuronal ceroid lipofuscinosis, where patient complains of developmental, the patient is brought to you with history of developmental delay, seizures and slow growth and visual impairment. There is no eye contact, no social smile, and the patient does not follow light in any of the directions. Again, similar to foveal hypoplasia, where there is subnormal vision and patient presents with nystagmus. This is because of instillation of Tropicacil plus eye drops in the NICU, where all the babies one day had yellow discoloration of the eyelids. And that was maybe because it was excess or whatever excess drops were put, they were not wiped off from the skin. And sometimes the pediatrician says that after putting in these Tropicacil plus drops, they had some cardiac issues also. So actual dilution is 1:1 dilution, 2.5% phenylephrine, which is a decongestant, and 0.5% of tropicamide, which is an anticholinergic. You can see the yellow discoloration around the eyelids. Then this was a case of antistaphyloma and sclerocornea, which we saw on 3rd of February. This patient was seen on 3rd of February in the Pandharpur NICU, where right eye is sclerocornea, left eye is huge anterior staphyloma with bilateral cleft lip, cleft palate. This again is a 20-day-old baby. Then sclerocornea, we have also seen loss of abduction in 6th nerve nucleus. This baby in the left eye, the eyeball does not move towards the lateral side. Then hydrocephalus, this baby was being always followed up for retinopathy of prematurity screening, and the baby had downward gaze. The baby just would not look up, and so we asked the pediatrician to see whether the child has hydrocephalus and look at the girth of the head circumference and the chest circumference. And the baby was then diagnosed for hydrocephalus and is now on treatment, and the parents say now the baby can look at the center or has a good vision and is taking treatment for hydrocephalus. Another patient which we saw was of limbal dermoid, microphthalmus, microcornea, which is very common, PHPV, persistent hyperplastic primary vitreous. We had 4 patients with congenital glaucoma and 1 patient with unilateral megalocornea. This is again we saw 15 days back, where we consulted Dr. Anand Vinikar sir. You can see the red vessels on the iris, that is tunica vasculosa lentis. This is again a patient from Pandharpur Cottage Hospital, where the baby, they have universal screening, so not a single baby is missed. So this baby was 1 day old and we screened this baby, and I was surprised to see so many vessels around the iris. And we asked sir that should we do something. So sir said no, we can wait for 8-10 days and then decide. And for my next follow-up on 3rd February, when we saw this patient again, this had disappeared and the fundus appeared normal. This is another case last night, yesterday evening in Karmala. This is a birth weight of 1600 grams and now the baby is almost 6 months old. It was 30 weeks of gestation. This was seen yesterday evening, 4th February, and it is stage 5 ROP. So we are trying to reach the interiors of rural Solapur district with the camera to avoid blindness, but still it is there. It is very sad to see stage 5 ROP when we are able to treat. We also take our lasers in the interiors to treat there only, so that the cost cutting is there and the patient does not have to travel all the way over here. But in spite of that, we are seeing stage 5 ROP even today. So, but we've called this patient for treatment tomorrow. We'll try and do something. At least the patient should have navigation vision. So we should not lose hope. Some treatment should be given even if it is stage 5 ROP or stage 4A+. These are few of the babies which are trying to see the external world because of our struggle of surgeries, lasers, anti-VEGF and then refraction. We are able to give them vision and help them see better. Thank you.
I request Dr. Kundan Chopde to come forward and felicitate Dr. Reshma Mehta, madam.
I welcome Dr. Girish Inghe sir, and he will take us now to Antarctica and freeze us completely.
Thank you very much, Dr. Reshma particularly, because on her request, probably. By the way, I too happen to be an ophthalmologist, and I am now Associate Professor of Ophthalmology in Ashwini Rural Medical College. I finished my MBBS MS from VM Medical College from here only, long back in 1984. Since then I've been practicing and working and everything, ophthalmologist. So first of all, I wish to thank all the speakers with their wonderful presentations and also laudable work, particularly Dr. Reshma, in this very, very difficult and challenging field of ROP. A lot of awareness is needed amongst the society, amongst the parents. Even with best of our efforts, we see the unfortunate cases of medical legal litigations, which is really unfortunate. But still, we all are doing that. We all are struggling and we are doing our best. So coming to my topic. In the month of May last year, one of my crazy friends, pointer. This one is a okay, thank you. One of my friends, he called me and said, Girish, actually my name is Sri Krishna on passport and everywhere. प्यार से लोग मुझे गिरीश कहते हैं. Anyway, through this dividing it into East Antarctica and West, and the geographical South Pole, that is 90 degrees south, 90 degree S, lies somewhere here, South Pole. So here some more details I am telling because it is really difficult to know actually. We really don't know the route also. So I am just showing some maps here. So we reached Buenos Aires. From Buenos Aires we have to go to Ushuaia, and from there the cruise starts. And then we go to Antarctica. While crossing from Ushuaia to Antarctica, we have to cross the Drake Passage. It is a passage of very turbulent and stormy sea. A lot of swells will be there, almost 5 to 8 meters high. So a lot of people get seasick in this passage. Now here we see a Beagle Channel. Beagle Channel is previously it was a transport route for the big ships because it connects Atlantic Ocean on east and Pacific Ocean on the west. Since the building of Panama Canal in the isthmus, which joins South and North America, this route is no more used now, Beagle Channel. Previously, before Panama Canal, this was the route from Atlantic to Pacific. Now here is just interesting information. This is the passenger nationality information on our cruise. that is Hurtigruten expeditions. There we see all over, the passengers are from all over the world, except 6 Indians, and that is our group, 6 Indians. Okay, so here we go, journey towards Antarctica from homeland India, experienced by yours truly, that is myself. This is the, like we started our journey on Mumbai airport. Here I remember a very beautiful ad, Limca ad. Most of us will remember that. There Limca before flight, like all enthusiasm and dancing, and Limca after flight, everybody drained off. Something happened similar to us because very, very long journey. Sorry. So here in transit from Miami. So he is by that crazy friend I told you, Mr. Rajesh Joshi, right? So when we reached Argentina, Buenos Aires, we took a free 4 days pre-cruise program because we are going so far. So we thought let us see something from that part of world, Argentina. So we took a 4 days Wild Patagonia program. Wild Patagonia is southernmost part of the Argentina. So for that, from Buenos Aires, we went to Calafate. Here is this a beautiful picturesque small town, and here is the first glimpse of, this is Lake Argentina, and here is the Andes Parvats, Andes Mountains. Our hotel at Calafate. In Calafate, there is no crops, only livestock, huge sheep ranches. So one of the sheep ranches. Again same Andes, view of Andes. Now this. Then one day we went to visit this glacier, Perito Morena Glacier in the Andes Mountains. Now this is supposed to be the one of the 7 wonders, natural wonders of modern world. Why? Because now ancient wonders, they are no more standing except pyramids of Giza. So they have enlisted new sites as natural wonders. So this is one of those. This is the Perito Morena Glacier, a very huge glacier, a beautiful glacier. And the importance is this is the only glacier in Andes Mountains which can be reached by a motorable road. So they have constructed very beautiful viewing galleries there. So we can see the glacier from close quarters. Also there is boat ride which takes us to the face of the glacier. Here is a small video. So this is the whole glacier we are seeing. It's a very massive. The whole width is almost 2.5 kilometers. This height is almost 50 feet, 15 to 20 meters. And the whole area of the glacier is 900 square kilometers. It's very, very huge, very beautiful. So this is that glacier. Okay. In the next, a small video is there. We witnessed a natural phenomenon of what is called glacier calving. Glacier calving means large chunks of ice, they break from the glacier face and fall down in the water below. And it creates a very loud, explosive sound. See, that is. So now the explosion sound is there. So this is glacier calving. Now after Calapathe, we went to Ushuaia, our destination. But still we had 1 day in our hand, so we cruised in the Beagle Channel. Like I said, Beagle Channel which connects east, on east side it connects Atlantic with the Pacific on the west side. And this is our first view of these seals. A lot of seals, they were resting on the rocks. A lone lighthouse in the Beagle Channel. This is the southernmost rock in that Beagle Channel. To warn the ships in ancient times, they had constructed a lone. It's like a monument now, geographical monument. Ushuaia, we visited the southernmost post office in the world, southernmost. We get a certificate like this from Ushuaia Tourism, southernmost city in the world, Ushuaia. From here we saw in that previous map, nothing is there but sea. So today is D-Day for us because we are embarking our cruise. This is our cruise, Fridtjof Nansen. The interesting fact about this is this Hurtigruten company is Norwegian. So they have named their ships after their Norwegian explorers like Fridtjof Nansen. Nansen. He is a great explorer of 18th century. One more ship is named after Roald Amundsen. Roald Amundsen is the first man who reached the South Pole in 1910. Even the restaurant of our cruise, on our cruise also, it was named after Lindström. Lindström was a chef who cooked for Roald Amundsen for his voyage to South Pole. Even all the cabins and all, they are named after this Norwegian explorers. In 1911, 1910, Roald Amundsen is reached South Pole. In 1911 also, British explorer Robert Scott, he also reached South Pole, but he and his 5-member team, they perished in their return journey from South Pole. But more famous is Robert Scott because of tragedy rather than the Roald Amundsen. Now we have entered the Drake Passage, a lot of winds and waves. Here is a small video, how was the experience. A lot of people, they got seasick in this journey. About it takes 2 days through this Drake Passage. The reason for this unrest is something to do with the cold currents coming from Antarctica and warm currents coming from the equator. So they create some eddies or something like that. That's why the sea is very turbulent in this. Now here is the prize video. First sighting of whales, a group of humpback whales just besides our cruise. Lot of almost 25 to 30 whales were there. We can hear their breathing sound also. That was really great. Some of these whales, they are tracked by attaching tracking devices by gun. Guns is not killing gun, they have got special gun. And one fella was tracked from 2006. He did they migrate from Ecuador to Antarctica in search of food and everything. On the third day, the captain announced, land, ahoy. Ahoy means ready, get ready. It's the sailor's language. Land at last, the fabulous 7th continent, Antarctica. So it's the first glimpse from the cruise. Lucky to have a beautiful weather, sun, it's 3 a.m. in the morning. In summer, that is December, Jan, Feb, sun never sets on Antarctica. It is always shining, but at an angle. The sun will be something when, like we are having at 10 o'clock or 4 o'clock in the evening. At that position, sun will be there always in the sky. Sorry. Hello Antarctica, here is a short video again. We are just excited, everybody. We are going to Antarctica, we are going to. So whatever is seen, we are trying to catch on photo or on camera. Yeah, so all. Okay, we are approaching the land now actually. See all icebergs, all these landscapes, because Dr. Reshma told me you put lot of photos. So I put lot of photos, but I will just go through it. White icebergs in blue Antarctica Ocean. This is navigation. This is our actual position when we reached Antarctica, means our site. South, 65 degrees south. So it is very close to the South Pole. South Pole is north. 90 degrees south. So we are just 25 degrees away from South Pole, but still it is almost 1500 kilometers. It's very huge, very huge. And west side, like I said, that we were in the West Antarctica, 64 degrees west. Now it's time for action. So decked up, dressed up for, not for any reception, marriage reception, but to land on Antarctica. Lot of layers, sweaters and thermal wears and almost 5 layers of clothing, then gumboots and everything. This ship, the mothership or cruise ship will stand in the water at one place and we go to the land on these small inflatable rafts. They are called zodiacs with all the protective gears and everything. Again, same here we see that deck number 3 from where they land the zodiacs in the water. They put the zodiacs, and also we step in the zodiacs on the deck number 3 this day. Yeah, so while going on the cruising, we encountered this huge iceberg with a lone penguin. It's a Adelie penguin. So everybody was contemplating why he or she is there alone. Maybe he or she fought with their spouse and contemplating life, something like that. But it was really all alone, very far away from the colony. That was interesting because that was the first sighting of a penguin in wild for us. So this is the actual landing on the Antarctica land. At last set my humble foot on Antarctica, landing on Peterman Island. There are various. We are there in Antarctica waters for 5 days. So they will take us around the Antarctica coast and will land at various landing sites, and they are named after various scientists. So this was the Peterman Island. Again same. We experienced a very heavy snowfall on this. This is the Orne Harbor landing site. And they put the expedition team, they will put such flags, and we are not supposed to cross these flags. They create a path by putting flags like this, and we have to follow those flags only. Otherwise, we may go into some crevice or some crevice only, because the surface is covered with soft snow, and below the surface we don't know what is there. So if we go in the crevice, we will rest in peace and cold in Antarctica forever. Okay, maybe next expedition will find us. So this is again very beautiful video of penguins. We came across a penguin colony there. So penguin walk along the penguin highway. They create their separate paths, see, like this, and we are not supposed to cross those paths, otherwise they will get confused. But here we get confused in Antarctica because they are the residents, permanent residents of Antarctica, penguins. We are the intruders. They don't know humans, they don't know any other things. Yeah. So penguin walk, the bird flew over there, it was a petrel. So that is our cruise ship. See the landscape, sir. Landscape, you must see the absolute silence, no disturbance, nothing. If you just listen, you listen to the silence. They say silence. Listen to the silence of Antarctica. Here is our tricolor. Our enthusiastic friends, they carried the tricolor with them on Antarctica. A research station on Port Lockrell, presently manned or women by 4 women team. There are a lot of permanent research stations on Antarctica, and there is no human inhabitation on Antarctica. No country can claim Antarctica. By 1955 Antarctica Treaty, it was declared as it will be saved only for research purpose. So no human habitations, no houses, nothing. But there are a lot of research stations. And in last month when we went there, it was womaned by 4 women team. Those 4 women scientists, they had come on the cruise and they interacted with us. They showed their work. One was glaciologist studying the glaciers. Here is the list of, just out of interest, I have taken this photograph from the cruise. Here are it is showing a lot of all the research stations in Antarctica. And over here we are fortunate to have our own research station, Indian Permanent Research Station. The name of our research station is Maitri, that is friendship, Dosti. And this is a very, very close encounter with a humpback whale, a very big fellow. It was just 10 feet away from our zodiac. And it was that small boat was tossing like anything. We were here, something here. And this is the hump on the back of that whale. That's why it is called humpback whale. Now they track these whales. The females, they carry the babies and they give birth in the water only. And they keep on feeding also till coming to the Antarctica, and they get very small. They say that they females, they become almost half to their original weight. Isn't it? It's a good idea, isn't it? But again they fatten up. In Antarctica they eat lot of their feeds and they go back. So mothers are all over the same, all over the world. They will feed their babies and they themselves will get weak. Very, very interesting information we used to get on the cruise. Back to the cruise, I am trying to get the Antarctic ice for our evening party. Yeah, these are huge icebergs. As we go closer to the land, the icebergs are really very, very huge. You will see a lot of these in our next photograph. And they keep on melting, and they melt very unevenly. So see here, it has formed like some radar antenna or something like that on the top of it. It's a iceberg. It's not land. Iceberg. The same. Sorry. Same. Huge icebergs. They are floating in the water. Now here one of the Antarctica resident. It's a scavenger bird. The name of this bird is kua. And if you see here, there are eggs. These birds, they lay eggs in the ice only, because the ice temperature will always remain 0 degrees. It will not go below 0 degrees. And so in the ice, they will lay the eggs, and with their body heat, they will incubate those eggs. This is kua bird. It will feed on small birds or on scavengers also, carcasses of whatever animals they are lying there. Now, for Reshma ma'am, various landscape photos now. Nature's beauty. See, now to see. Lot of photos. See. Now here the interesting is, now the time in our watch was 11 p.m. Okay, but see the sun. The other time it was 3 a.m. in the morning. This is 11 p.m. We can say only AM, PM, not night, morning, something like that. Because constantly 24 hours it will be like that only. So sun will never set. Apart from British Empire, this is the Antarctica in summer. Okay? Because they used to say, no, the sun never sets on British Empire. Okay? So this is yours truly in the Antarctica ice. Again, one of the beautiful penguin colony. Same again. What a beautiful scene. See, again same, Antarctica, landing. So this is how our landing site will look like. Here we have went up to here, but in the zodiac, and they will have some small trekking on the land, something like that, for 1 hour or so. Again same, some landscapes. These are hot water pools on the cruise. So those who are interested, they can have a hot water, sit in the hot water pool, enjoying the ice surrounding you. Okay? So उल्टा होता है, ग्लास में आइस होता है, हम बाहर रहते हैं, इधर बाहर आइस है और हम अंदर है, ग्लास में है. Okay? Yeah, same again. So this is one more cruise they had come there. So these are the zodiacs which we go in the water for cruising and landing. Again same, this is the iceberg with a very peculiar shape. Same again, iceberg. See, it has taken what a shape, like a castle. There is a tunnel. Tunnel has formed here, a huge pillar. This is only, what we are seeing is only, you all know, 1/9 or 1/8 part of the iceberg. The remaining 7/8. So underwater. Underwater it will be 7 times bigger than this. That's why Titanic sunk. Same again. Now some beautiful close-ups of penguins, they are permanent residents. They are looking at us. Who are you? They are asking us. Again, face to face with a Gen 2 penguin. This is the smallest penguin, Gen 2. Beautiful. It can be identified its red beak. If you are interested, this is the chin stripe penguin. If you see here below the beak, there is a stripe along the chin. That's why it is called chin stripe penguin. Again, beautiful penguins. They are going for fishing now. There is a beautiful video. Again, this penguin calling somebody, we don't know. Sometimes the penguins, they glide over the snow on their tummy. It is sufficiently insulated with a big pad of fat, and they glide easily on the snow. Again, same, a very, very beautiful photograph. You can see the eyes also, looking very peaceful. So let's go fishing. This is the penguin going fishing. See. They are standing in line, one behind one, ready to jump. Yes. Penguins have no natural predators except one, that is orca. That is one, and one more common is leopard seal. So if there is leopard seal around their colony, they will be very careful before going to into the water. So again, these are some landscapes. We see nothing but snow on Antarctica, always white. But here is the one landscape. It's called Deception Island. Why? Because when the sailors or whalers, they went there, they expected like all white snow everywhere. But instead of, they were deceived and they came across this landscape. That's why they named it as a Deception Island. You deceived us. Why? Because it is a volcanic island. Some 2-3 centuries back, this volcano collapsed and the whole caldera was filled with water. Now the cruise, it goes inside the caldera, stands somewhere, and we go around the island. Again, some landscapes of Deception Island. We saw this yacht in that Deception Island. So this is our last landing site at Deception Island. So again, though it is not covered with snow, but temperature was much low, almost -2 surface temperature. So again, we had to go in all our gears. And with that, bye-bye Antarctica. On the same day, on the 5th day, we started our return journey, and this was the last photograph we took from the cruise. So thank you. Thank you very much again for the organizers for giving me this opportunity. It's a totally out of way journey. First, thinking of it, how to go, is difficult. Okay, thanks a lot. Thank you very much. Thank you, Ashish. And I thank Ashish, my PG, for helping me in preparing this presentation. I hope you have liked it and you have enjoyed it. Thank you. It was antidote against a very, very heavy ROP. Okay, thank you. Sorry? Tour duration from here, tour duration is actually 15 days. Means from Ushuaia it is 11 days. Okay, from Ushuaia it is 11 days. 3 days to Antarctica, 5 days there, and 3 days back. And to reach Ushuaia, it's up to you how you go, because there is one direct flight from Abu Dhabi to, but say 24 hours to reach Ushuaia, means Buenos Aires to Ushuaia. 24 hours going, 24 hours back. But those flights are very costly. So that's why we took this. So Cost, it costed us 10 lakhs, 10 to 11 lakhs per head. Water, yeah. We stay in the cruise only. Total cruise is 11 days, 3 days going there, 5 days there in Antarctica, 3 days coming back. Pre-preparation is, one is finances. So you have to prepare finances because it's a huge amount. But fortunately, we pay in this not at a one time. There is some booking amount, then various at various stage, so we can manage that. Then nothing special. This for cold only we need when we go to Antarctica. Go on Antarctica. A cruise is like this, very comfortable. And temperature on Antarctica surface was something about -5 to +5 degrees centigrade, tolerable with layers. And cruise was this modern cruise. We have got 24 hours Wi-Fi through satellite. So even in such a remote place, we had Wi-Fi, and I used to connect daily with our near and dears. I used to actually give daily updates to all my groups, all these photographs, daily updates. Okay, thank you, sir. Thank you, thank you. December. Yes, November to February, because there is summer at that time.